All right, guys, ready? Yes. All right. So, just to let you know, the quiz is going to be next week. Please be extremely prompt. I'm going to be starting it up right at 8 o'clock on the dot. So, the old adage goes, on time is late, early is on time. So, it might behoove you to be here on time or a little early. That's all right. Anyway, it'll go up through the stuff we're going to learn today, so I may have to modify it a little bit based off how far we get, but it will go through anything we covered today. All right? It's a lot of matching, multiple choice, some true false, just kind of a mix of stuff that I don't normally get to do on tests, just to try it out, just see how we like it. If we all hate it, then maybe we'll just go back to straight multiple choice, but it's kind of just different for me. So, I don't know how many questions specifically, because like the matching is like each one of those is a question, right? So I might have like a list of like several different drugs and matching them up to a mechanism or matching them up to a side effect or an antidote or something like that, right? So kind of each one of those is a question. So I can have a lot of those. It may count for less overall, right? Because you have a lot of them all together, but there you go. It's like 5% overall the total grade. So there you go. Anyway, so we talked about chemo last time. We get into something I like a whole lot more to talk about is going to be pain management, and I kind of lump it in with like the ortho stuff. So this is mostly just going to be about pain management because a lot of ortho is about pain, and we already learned about other things like anticoagulants. That's really important from an ortho standpoint because with a lot of those surgeries, if you have like a hip replacement and you're laid up in bed after surgery, what's likely to happen? Just DVTs and things like that. So we've already talked about anticoagulants, and so that will play a role here as well. But mainly want to focus on the new drugs that we haven't really covered before. So pain management. Basically, what is pain? It's very subjective, right? So I can say here right now, my pain is a 6 out of 10 on a scale of 10, right? You may not look like it, but it could be a 6 out of 10 for that person, right? I always ask patients to say, listen, on a scale of 0 being no pain whatsoever, and a pain of 10 being I'm sawing off your arm with a blunt spoon. What's your pain right now? And they're like, I'm an 8. And I'm like, you're sitting there comfortably. Your vital signs are all good. Like, you look great. You're an 8 right now? Really? Like, the spoon with sawing off your arm? And they're like, yeah, I'm an 8 right now. I'm like, all right. That's what you say, right? So again, if we could find some objective way to find what a patient's real pain is, like you'd be a billionaire, right? So it's very important. But we have to take our patients at our word in a lot of cases here. But very, very common complaint why patients are going to be presenting to you in the ER, in the clinic, wherever the case may be, whether it be acute, whether it be chronic, and it's important to know how to manage those patients. So what are some barriers to proper pain management? Some of it can be related to the patients, right? There's a lot of stoic patients out there that are like, I don't want any meds. I'm too tough for that, right? I know some ladies who are like, they're about to give birth and they're like, I don't want any meds. I want to do it all natural. And I'm like, why? Why? We have such good drugs for you. My wife's like, nope, I want the drugs immediately. As soon as she walks in the door, she's like, when can I get the epidural? And they're like, we don't even know if you're like in labor or not. She's like, I want it right now anyway. Do it. But yeah, there's legitimate fears about things like addiction, about adverse effects, etc. So there's a lot of issues related to the patient. How about with the healthcare providers? What do you think? They can be extremely judgy, right? So you'd be like, I don't think you're really in pain. You say you're in A, but I don't think so. I'm going to give you this instead of this, right? Or I might not give you anything at all. Or there's people who make blanket proclamations. They're just not going to give out opioids at all. They're just never going to do it. And it's like, well, there's legitimate cases where it's absolutely necessary, right? There's pharmacists out there who say, I'm never going to fill a C2 prescription. I think that's kind of irresponsible, right? Because there's patients who legitimately have needs for some of those medications there. But it's that fear of like they're just junkies, they're just addicts, they're just looking for pain meds, and that's not appropriate in every single case. Now, are there people out there who are doing that sort of thing? 100%, absolutely. But as clinicians, your job is to not become so jaded that you think that every single person walking through the door is trying to get meds from you, right? Again, it could depend on where you're working at. It could depend on what type of setting you're in. There's a lot of different features. My wife she did her second year residency in pain management at the VA, and so she had to do part of her rotations in the pain management clinic there. And I mean, like, I remember this one funny story where this guy would come in, his little hover around scooter, this vet, and he had this lady who was always on his lap whenever he come rolling into the pain management office. And I mean, this lady was like dressed to the nines. She had I'll get back to that. But she was, just makeup done, jewelry, everything looked great. And he'd come in and he'd get his Percocet every single week, And then all of a sudden they decided to switch him off to something else that wasn't quite as maybe say lucrative. And all of a sudden the lady stopped coming with him. I felt bad for the guy, right? So anyway, so there's a lot of features that go on out there that you have to consider. But other things, there could be issues with barriers in the system. So there may be lack of medication availability. There could be lack of access. Maybe few practitioners who have a lot of standardized training in pain management. That is certainly a big issue. Because again, if you're just coming out of, say for instance, you're coming out of school and your first job, and they're like, all right, well, manage this patient's chronic pain. Are you going to be an expert on knowing what to do? Not really. Like, you'll have the basics here, but you're not going to be an expert in that sort of thing. That's where a lot of training, specialized training, can become very useful, right? And also just an issue of reimbursement, right? So again, there could be issues where you're not being reimbursed for that specialized training or for that special care. That can be another barrier. So understanding pain, it's a very subjective thing. I'm not going to be able to perfectly define it here, but it's essentially whatever the patient says it is. If they come in and say they're a 10 out of 10, you kind of have to take them at their word. Now, there's some other things you can look at to assess a patient's pain. What could that be? Their blood pressure should be what? Probably elevated, right? What else? Physical appearance. Do they look really distressed? What should their heart rate be doing? Diaphoretic. Heart rate should be probably elevated, right? But however, you have these chronic pain patients who that's just their normal now, right? And so you may find that their blood pressure is fine, heart rate's fine, diaphoretic, they don't look distressed, but they are in certainly a lot of pain. So again, it's a very subjective sort of thing. It's interesting. You'll find some of these patients with chronic pain, they get very much tied to their number, right? So they'll say like, well, this is my pain. My pain's a 6 out of 10. And so you'll come in, you'll change all the regimen and everything. You come in the next day, be like, how do you feel? Oh, I feel a whole lot better. I can actually get around, do some more stuff. And like, what's your pain? That's still a 6 out of 10. Again, it's a very subjective sort of thing. So again, take all the factors into it when you're discussing pain with your patients. So there's acute versus chronic pain, right? And this chronic pain can either be persistent or intermittent. When I say intermittent, what do I mean? It comes and goes, right? It could be related to activity, it could be related to the weather, it could be related to all sorts of things, right? And so the three main types we're going to talk about is going to be either somatic, neuropathic, or visceral. For our purposes, you can kind of lump somatic and visceral together. Visceral just means like what? Like organ pain, think about someone who's like presenting like appendicitis. That's more like a visceral sort of pain. Neuropathic pain is going to be related to, obviously, the nerves, right? And so you think about diabetic neuropathies, you think about things like MS, you think about all kinds of different disease states. It could be linked to neuropathic pain. The treatment for somatic and visceral pain is going to be pretty similar. The treatment for neuropathic pain is going to be a little different. So we're going to look at some different medications we can use for that. That's where a lot of our anti-epileptics and things like that are going to come into play. Meds we're going to talk about more later on this semester. So as I mentioned, the acute pain is going to be lasting hours to weeks. Typically, there's a known cause for it, so whether it be surgery, trauma, etc. And it typically is going to go away with time. And typically does respond pretty well to analgesics, as we'll see here in a minute. Chronic pain is going to be lasting for sort of an indeterminate amount of time. It could be months, could be years. And this is where we're going to be focusing on things like multimodal sort of treatment modalities. So for instance, if the issue is that they have a lot of knee pain due to osteoarthritis, well, what can we do besides just giving pain meds? Well, let's give them a whole new knee, right? Let's just give them some hardware, and that could help to deal with the pain, right? So, for instance, my mom just had bilateral knee replacements, right, over the course of several months, and that has helped tremendously with her pain. Now, she doesn't have to rely on things like opioids and analgesics around the clock to help with that pain. It's been a big help. So, again, multimodal sort of therapies are going to be very, very useful here for chronic pain. So, as I mentioned, I'm not going to get into necessarily how to describe the different types of pain, because you get that, that's what's part of your history taking, right? To describe the pain, and that will clue you into what type of pain it is, right? So if they say it's burning and tingling, you're thinking what kind of pain? Or neuropathic, right? Versus if a throbbing, dull, ache, you think more of a somatic sort of pain there, right? So, and you guys are kind of familiar with that already, so I'm not going to belabor that point. But we do know very, very costly, because you have loss of work, you have loss of, you have disability associated with this, and there could be a lot of issues with quality of life, not only the physical impairments, but also just the psychological impairment of constantly being in pain, a lot of issues there. So certainly a lot of cost, which is why it's very, very important we have appropriate pain management. And again, optimal pain management is dependent on optimal pain assessments. We talked about a few ways to do that already. What are some other ways? You can just talk to the patient, try to get a gauge on their pain. Yeah, like Wong Baker. What is Wong Baker? Yep, so you have like the faces pain assessments, and I'll talk about that in a second. And again, this is your OPP-QRST, right? So you want to know like what the onset is, what makes it better, what makes it worse, where is it localized to? Is it radiate? All those sorts of things, right? So you guys are very familiar with that. It's all part of your history taking and writing your notes and whatnot. So I'm not going to get real specific on that, but these are things you have to ask. And it's important to ask those questions multiple times, especially over a period of time. You want to see what the delta is. You want to see, is it getting better? Is it getting worse? Because that can inform you as to what you're going to do from the medication management sort of aspects here. Again, and I'm going through this quick, but I have a lot of slides, so I don't want to get to the meds because I think that's probably the important thing here. But and think about the verbal analog scales. We already talked about that already. 0 being no pain, 10 being the worst pain of your entire life. And again, sometimes I find like giving like some extra descriptors kind of helps to set the patient in the right mindset. So that's why I use the blunt spoon sawing your arm off kind of thing. So that way it kind of like clues you in. I'm not just talking about like you stubbed your toe and, oh, it's a 10 out of 10. It's like, no, like this is really, really painful. Here's a YouTube clip you can watch on your own time. It's kind of a short thing about this guy who goes to the ER. And he's trying to figure out what's the right number to tell the nurse that he is, so he can actually get like, you don't want to tell him a 3 because then you're just going to get Tylenol. Like you don't want to tell him a 10 because then someone's going to be like, there's no way you're a 10. Like 8 is just perfect, and then you get like morphine. So you can check that out. It's kind of funny, but it's legitimately like sometimes people have this thing running through their mind, like, what if I tell you the wrong number and I don't get my pain addressed effectively? That's a legitimate concern with a lot of patients, right? So other things, I kind of like things like this 10 centimeter visual analog scale. That's kind of nice because you basically tell the patient to point to where they feel like their pain is. And so what's kind of the benefit of this, do you think? Yeah, it's not like a number they get locked into, right? So again, you can basically measure the distance and measure that change. That way, if I give you a dose of morphine, I come back in, they're not going to just sit there and just say hit the same number over and over again. But if they actually feel a little better, maybe they're going to, somewhat subconsciously like go maybe a little bit more to the left, and then I can check that difference there, that delta, and say like, well, they had a 2 centimeter improvement in their pain. That could be pretty significant depending on what the case is.
What if they have dyslexia and the line keeps moving?
I don't know, maybe that's just not a good scale for them. It's a very good point, absolutely. But that's a very good point as well, that no one scale is going to be perfect for every single patient, right? Again, we mentioned when you're dealing with children, doing the Wong-Baker FACES scale can be useful, right? So, or people have like maybe some kind of cognitive impairment where they're not able to understand maybe what you're talking about as far as the numbers go, but like, what does your pain look like? Does it look like the, this guy crying? Is he actively crying, or is it more just kind of like, I'm just kind of sitting here, So that can be somewhat useful. You think about older patients with geriatrics. Like, has anyone ever actually seen one of these type of thermometers in person before? Most of you younger pups probably haven't, because we don't really use those mercury-based thermometers anymore, because it turns out mercury is very dangerous. But older patients, they probably grew up with a lot of these, right? They had to go outside and actually see what the temperature was off of one of these, and so they would have a little bit better attachment or a better association with that. So yes, ma'am.
I think there's a new one in a lot of offices.
Yeah.
And it's like, I don't know, like 3 stung by a bee and 10 mauled by a bear. Very descriptive.
There you go.
Yeah.
But also the thing is, like, if you've never been mauled by a bear, how do you know what that pain is like, right? Or you could say this is like giving, like, they talk about like, guys getting kidney stones, attributing it to, or being similar to giving birth. And it's like, I don't know, I'm never going to give birth. I don't presume that I'm ever going to give birth in my lifetime, so I'll never actually know what that pain's like. But if you talk to a lady who's had a child before, you could be like, this is going to be like childbirth, or like, where is it on the scale of things, So yeah, it's all about how you talk to your patient, how you make that connection with them to make sure you're talking on their level, right? So that's the big thing to consider there.
I also don't know how it feels like to get my arm chopped off by a spoon.
That's true too, but I'm trying to but sometimes by painting a picture, like you can at least like try to like make them think like this is the absolute worst pain you could ever feel. But you're absolutely right. Like no one's probably ever. There's some amputees out there, but hopefully they did it with not a rusty spoon. So I don't know. Anyway. There's no foolproof system. That's an important point there. But again, ask about, what are the other associated symptoms? Do they get numbness? Do they get, tingling associated with their pain? What are the modifying factors here? That's really important. Is it only, does it only get worse when they start to get up and walk around and be active? And you tell them, well, just don't be active anymore. It won't hurt, right? It's like when you really stub your toe or something as a kid, and then your dad kind of hits you on the other toe and be like, oh, there you go. Now that doesn't hurt so bad. Maybe my dad's a little abusive. I don't know, but I'm just kidding. He's a great guy. He's a great guy. But yeah, and then other things like looking at other scales that are out there. There's a million different scales that are out there. That's one of the big problems, is there's no unified one way. So if you go work at Florida Hospital, their way of doing pain assessment and management is going to be far different than if you were to go to ORMC or if you were to go to any other hospital system, because there's just not one unified system out there, because it is so subjective. It's very, very tough from that standpoint. So other things you want to figure out, what's their medication history? Is the medications they're on maybe exacerbating their pain? Could there be something playing a role there? Their physical assessment, basically, where is the pain actually located to? Is it worse in certain areas than others during certain times? Organ function is going to be really important here, not only liver function, but renal function will dictate whether they can clear some of these meds or not. And then obviously looking at things like history of substance abuse. Could be family history, could be personal history of substance abuse. Now, if they do have that history, are you going to be as likely to give them opioids? Probably not, right? They may be very hesitant to even use opioids, especially if they've recovered well. But sometimes they may actually need opioids, like especially if they're going to surgery, they may actually need it. And so it can be very, very tough when you're dealing with patients with that active history there. And then, of course, looking at things like psychosocial assessment. Usually, a lot of these chronic pain patients are going to have some sort of psychiatric comorbidity. We're going to talk about that later in the psych section, but think about things like depression, think about things like PTSD, think about all these other comorbid conditions that could be exacerbating their pain. Anyway, so in dealing with moderate to severe chronic pain, the thing you have to think about is it's not always one single level of pain all the way throughout the day. There's going to be peaks and valleys, right? And so what you call this is going to be these kind of breakthrough periods of pain here, where their pain, while normally may be managed with medications normally throughout the day. If you imagine the blue line being sort of their pain, their analgesics being on board, normally it would cover most of the pain, that basal pain throughout the day, but there's going to be periods where you have these breakthrough moments. This is very common for patients who are on chronic pain management to be on something around the clock, long-acting medications, and then on top of that to be on something for breakthrough pain. Those are usually going to be immediate release, fast-acting sort of medications. It's important to understand. So when you see a patient who's on Oxycontin, which is a long-acting form of oxycodone, and then they're on Percocet on top of that, which is oxycodone plus acetaminophen, that is a valid way to handle that pain potentially. So that way they would say be on Oxycontin Q12 hours. It's usually 12-hour acting sort of medication, depending on who you talk to. And then they would be on, say, the Percocet Q4 to 6 PRN breakthrough pain, right? And so, again, that's a very common modality. It's okay if you see a patient have multiple opioids on their profile. Oftentimes it's due to management with chronic pain. Now, do I need to do that with someone who, say, has, comes into the ER with a dental infection and then they're going to be sent off for 3 days of meds? No, they don't need that, right? You typically just stick with short-acting medications. This is more for the chronic sort of pain you're going to be dealing with, right? Or say, for instance, you had someone who's on the inpatient side after surgery and you're managing their pain in the post-operative period, you'd use a similar modality here. It would just be for a shorter period of time. So typically our approaches, there's a ladder sort of approach, and you want to go on a stepwise approach when you're dealing with these patients. The WHO has a pretty good one where you're going to start off with, say, something like a non-opioid, maybe some sort of adjuvant medication, and then if they're still having persistent pain, you jump it up and say, okay, well, maybe we'll consider using opioid for mild to moderate pain. And you jump it up further if they're still having issues, and this is where you're using things like IV medications, IV opioids, things like that. Now, if someone does come in and they say, oh my gosh, my arm just got sawed off with a dull spoon, you want to start off with well, here's some Tylenol. Let me give you some of this at first, see how you do, and then we're going to bump it. No, you can start off at the top step, right? So depending on the clinical situation, you can hit them with some hardcore IV opioids right off the bat, and that's totally appropriate, right? So if someone comes in with a femur fracture, I'm not going to start by giving them just a little bit of, ibuprofen and Tylenol and saying well, let's see how you feel in 15 minutes. They're in pain right now. I would need to give them some IV fentanyl or something, right? So again, we'll talk about the different meds and where they fit into these categories here. But in a lot of times, what you'll actually find as well, especially in patients, and say, for instance, they're post-op, they just got out of surgery, the big thing you want to do is try to get them off all opioids as soon as you can. We're going to find out why that is in a little bit, but the sooner you get them off opioids, the sooner their guts are going to wake up and they're going to start to pass gas or be able to have a bowel movement. They're going to be able to get up and ambulate better. The faster you can get them discharged, right? Because again, the hospital is the worst place to get healthy, right? So you want them discharged as soon as you can. And so what we'll do is we'll have different steps of medications on their profile. So that way, if their pain is only a 1 to 3, maybe you'll only give them Tylenol, right? If it's a 4 to 7, maybe we'll give you some oral opioids, right? We'll give you something like an oxycodone. If their pain's a 7 to 10, you maybe need some IV morphine, right? And so by doing that stepwise approach there, you try to get them off of the opioids as fast as possible, hopefully get them off the IVs as soon as possible, and get them discharged that much sooner. So that's kind of a big approach you're going to see in a lot of standard inpatient orders. Or in a lot of you guys may go into surgery, and when you're writing these post-op orders, which I see a lot of my graduates do all the time at Amores, they're writing orders similar to this kind of paradigm. So anyway, so again, as I mentioned, the misconception is the patients just start on the bottom of the ladder. Absolutely not true. Figure out where their pain's at right now, and then start them on the appropriate step there. Okay, so getting into it, let's talk about inflammation initially. We've talked a lot about inflammation already in various other parts of the course here. Same thing's happening here, right? We're releasing histamine, we're releasing prostaglandins, we're doing all these different things that cause vasodilation because we want a lot of blood flow to the area, we want a lot of we want heat there, we want to try to stimulate the immune system to deal with that injury that's occurred there, right? So what are some meds we can use to help deal with that inflammation causing a lot of that pain? NSAIDs are going to be a big one, right? So we can use NSAIDs. Corticosteroids can also be used, absolutely. Yeah, so again, we already talked about a lot of these meds already. We're going to kind of talk about them briefly in the kind of the point of, as an analgesic, not necessarily just as an anti-inflammatory. But when you have all these different inflammatory cytokines being released, they're sensitizing those pain fibers, right? So you have the fibers actually directly at the site of injury. They're going to be sending those signals where to? To the brain, right? So they have to go to the spinal cord. They're going to synapse there in the spinal cord and then transmit up through the brain. Okay, so you're going to find there's already a few steps of the process where we can interfere with that pain. We can do it directly at the site of injury. We can do it in the spinal cord, and we can do it up in the CNS. Okay, so for instance, what's another way we could do it? If I didn't want to maybe deal with the inflammation from an analgesic sort of standpoint, what if I just deaden the nerves entirely? They could use something like a local anesthetic, and that will actually numb it up completely, and that way they never transmit that signal that they're having pain up to the spinal cord into the brain. So there's a lot of different modalities we can use here, and in fact, one of the big ways, especially with like big orthopedic procedures, we're giving them local blocks, nerve blocks, so that way that signal of pain is never getting to the brain. They don't know they're in pain necessarily, and they don't need as many opioids. So that's one of the big things we're doing to spare opioids and hopefully get them recovered that much faster. So if you ever see like a nerve block or a local block or something like that, that's what we're doing, is trying to deaden up those nerves. And we'll talk about those meds a little bit later on in the course and how we're going to use those effectively, right? That's like lidocaine, bupivacaine, things like that. So anyway, as I mentioned here, you can see that the tissue injury is going to be causing these nerve fibers to be sensitized. They're going to be sending off a lot of signals up through the spinal cord and then eventually up to the brain. Here is where you're going to find that things like our opioids are primarily going to be working, right? They're primarily working at the site of the spinal cord and the brain to try and deal with those pain signals, to try to limit how much of that pain signal is actually making up to our consciousness, essentially. So anyway, so our anti-inflammatories are going to be working to inhibit things like prostaglandin synthesis. They're going to be blocking that permeability changes, so you kind of deal with that edema, that the redness, that heat that's happening there, and hopefully prevent things like leukocyte migration and whatnot. And we've already talked about a lot of these. They also, by decreasing those inflammatory cytokines, they kind of limit that sensitization of those pain fibers, and so not as many of those signals are going to be making it to the spinal cord. Typically, these anti-inflammatories are going to be better for mild to moderate pain. Someone comes in with a femur fracture. You can use this as an helpful adjuvant med. You can use it as an adjunctive med where they're kind of helping out, but they're not going to be the primary thing to deal with the analgesia, right? You still need something that's going to be working much more centrally in order to deal with that really significant pain there, but good for mild to moderate pain. And also it's important because a lot of these meds are available over the counter, so that means patients are going to do what? They're going to be self-medicating, right? So you need to be aware of what they're taking themselves, and it's important to ask them when they come in for a painful complaint, what have you already tried? They said I already tried ibuprofen around the clock and it just isn't doing anything for me, and you try to give them more ibuprofen, what are they going to do? Like, dude, I already told you that doesn't work for me. Give me something stronger. I need something else, right? So it's important to take that history into account there. Now, we've talked about cyclooxygenase before. We know it's important for things like platelet activation. Remember, there's two forms of cyclooxygenase, COX-1 and COX-2. COX-1 is constitutive or inducible? It's constitutive, which means always around, right? And that's important for the side effects we're going to be looking at. Now, when you have an injury, tissue injury, what gets induced? COX-2 is going to be the thing that gets induced there, right? So that's very important for the blood vessel changes, the inflammatory changes there. And so that we're going to talk briefly about COX-2 selectivity. Now, the majority of NSAIDs we talked about so far have been non-selective, right? So things like your ibuprofen, things like your naproxen, aspirin are non-selective inhibitor of COX-1 and COX-2. And it normally led to side effects like what? Yeah, the GI ulcers are the big thing, right? Because again, you're inhibiting that prostaglandins, they're not producing the gastric barrier, and so you end up having stomach acid eating through the stomach tissue there, causing the ulcers. That's a big thing, right? You also saw a lot of that anti-platelet sort of effect there, some bleeding risk associated with that. However, it's more pronounced with which NSAID? Aspirin. Why is that? Perfect. Yeah, it's an irreversible inhibitor of cyclooxygenase there. All the other ones we're going to talk about are reversible, so bleeding risk is going to be relatively minimal, mostly when the drug is actually around in the system, right? But it's still there. You still want to be careful if they're on other meds. So, for instance, if they are getting an orthopedic procedure, and it's particularly a bloody procedure, and they're on NSAIDs, that could then worsen that bleeding there. So that's something you may want to avoid in some of those cases, right? Things to consider. So, looking at this etiology-based sort of treatment plan, you can see here for somatic and visceral pain, this is where our NSAIDs Acetaminophen and corticosteroids can be used for more mild to moderate sorts of pains, and then our opioids are going to be sort of the hallmark there. We're going to be looking at those in depth in just a few minutes. For the neuropathic pain, this is where we're going to be focusing on some of these sort of ancillary sort of meds, things like antidepressants, anticonvulsants, even things like muscle relaxers like baclofen. Again, we'll get into all of these, and then plus or minus on the opioids. Typically for neuropathic pain, you want to avoid opioids if possible, mainly due to the fact that they're going to be effective, but they're not really dealing with the actual nerve issues. And again, if we can get patients off of opioids, that's always going to be a good thing, right? Fewer opioids is better. So anyway, so looking at dealing with this, we're going to find, especially with chronic pain patients, you need to go with this multimodal sort of approach here. Consider, do they need concomitant CBT to go along with their chronic issues, the cognitive behavioral therapy? Do they need to have PT, OT involved? Do they need to have all these different things in order to try to deal with these issues here? And when you're assessing your goals, ideally, what's your goal in treating pain? You'd have no pain, right? You'd ideally have 0 pain. They go to a 0 out of 10. Is that possible for all patients? Absolutely not, right? Some patients are always going to have pain. The question is, can you at least make it manageable for them, right? Can you at least get them to the point where they can get up and walk around and be functional again? Can they go to work? Can they go and do the things they normally like to do? That's an important thing, right? But make those goals clear with your patients. Let them know that, listen, this is not going to be a magic bullet. It's not going to fix every single issue, but what's going to be considered a success to you, and try to come to a compromise there, right? Okay. Again, the treatment has to be individualized, so not every single patient can be treated exactly the same, whether it's the dosage form we're giving, whether it's the drugs that we're selecting. We'll talk about all of that in just a little bit, and just to be aware that different patients will respond differently to opioids, right? So you're going to find some people, you give them hydrocodone, and they get super euphoric, and they love the stuff, and then they eventually maybe become addicted. That can happen. You give some people hydrocodone, they get sick to their stomach, they throw up, they hate it, I never want to see that stuff ever again. Everyone's going to be a little bit different when they get these opioids, so it's important to consider that. And just know that sometimes patients need multiple different drugs. Again, we hate to use more drugs if you don't have to, but sometimes that is necessary. And again, by using different mechanisms, you get better synergy there, right? Okay, so we're going to talk about our different options here. So we're going to talk about acetaminophen briefly, or NSAIDs, opioids, and then finish up with our adjuvant meds here. Okay. So Tylenol, we probably talked about it briefly in terms of what uses. For pain, what else? It's an antipyretic, right? So we can use it for fever, very good for that stuff. Is it a good anti-inflammatory? No, it is not anti-inflammatory. It should not be lumped in with the NSAIDs. Can I use these at the same time as an NSAID? Absolutely, yeah. So again, I see this very frequently. I kind of use both of these together. In fact, one of the things our ENT docs like to do, say they have a patient who is getting, say, a tonsillectomy, adenoidectomy, getting admitted. Oftentimes what we'll do is they'll just have orders for acetaminophen and ibuprofen, and we'll actually cycle them every 3 hours. So that way they get, say, acetaminophen at 9 in the morning, they'll get ibuprofen at 12, they'll get acetaminophen then at 3, and then they'll get, so by doing that, by cycling those through, they help to provide better sort of long-term coverage without ever having to use opioids. They actually find that's opioid sparing when they do that in studies.
You know how both are metabolized via the liver?
Mm-hmm.
Could that cause issues if they're constantly taking it back and forth?
Not typically, right? So NSAIDs typically are not considered to be hepatotoxic for the most part. Okay. Maybe if you're taking very large doses or something. Acetaminophen, absolutely, and we'll mention that for sure, because acetaminophen is always by itself. A lot of times you can find it in combination with other drugs, and so it's an important point we'll talk about in just a moment here. But anyway, again, if you ever want to know where the name Tylenol comes from, it's actually with the chemical name there. But good analgesic, good antipyretic properties here, very widely used from mild to moderate pain. So if I have a patient getting admitted and I have several meds for their pain on their orders, oftentimes we'll tell them, PRN for pain scale 1 to 3. Mild pain is going to be good with Tylenol. Now, why do you think I make those distinctions? Why can't I just say PRN pain for all these different meds? Yeah, so think about the scope of practice for nurses. Can nurses independently decide what meds a patient should get? Absolutely not. They are following your orders. So you have to be very specific about what they can give. Now, again, as a nurse, think about the best nurse you ever met, very well seasoned, very experienced nurse. Could they make the decision what meds a patient should get? Absolutely, they can figure it out. They know how to take care of patients better than we do sometimes, right? Absolutely, but it's their scope of practice. So when you have the Joint Commission come through, and they say, well, why are these nurses making these decisions? It's not in their scope. You get in trouble, right? So that's one of the big things we did last time we had Joint Commission come around, was to make sure that we had very specific indications there saying the nurse, when they ask the patient, what's your pain scale? And it's a 3, they go back to their orders and say, okay, it's a 3, so I can give this med. Or if it's a 6, I give this med. Or if it's a 10, I give this med, right? So you have to be very specific about that. And boy, we had some docs who were not happy about that. So we had, for instance, we had this one really curmudgeonly I mean, he's probably, had been practicing ortho back in like the 1800s or something. But this guy, and we'd have these orders that would come through for opioid meds for these kids that were post-op. And we'd be like, hey, we got to add, these indications on here. What can I put on these orders to make them so that the nurse can follow? And she's like, my nurses know how to figure it out. I agree, but unfortunately we had to go with the regulations. I don't even care, blah, 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 and hang up the phone. It's like, well, I still got to get these orders fixed, right? So it can be very tough, right? So again, you want to make sure that you're following the regulations, you're following the rules, because yes, are those nurses smart enough to figure it out? There's a lot of them that absolutely do. Are there some that I do not trust as far as I can throw? Absolutely as well. That's the other thing too, right? So again, I'd like every nurse to be as good as my mom or something, but that's not always going to be the case, right? There are going to be some out there that need that sort of instruction to be very explicit for them. And again, that's good from a regulatory sort of standpoint. Anywho, so again, Tylenol, very well tolerated for the most part. That's why we use it for things like osteoarthritis. Is the number one drug out there as far as analgesics go. As far as just in terms of use, very, very well tolerated. The big problem you have to worry about is what sort of organ dysfunction. Hepatic, right? So again, this is very hepatotoxic if you're using too much of it. What's the problem though is it's over the counter. So I can go to Costco right now and get a 55-gallon drum full of Tylenol and self-medicate myself till the cows come home or till my liver gives out, right? It's probably going to happen first. And so that's a big problem, right? So you're going to find that you need to let them know how much is too much to take. And not only that, but make sure that when you give them a prescription for something that has acetaminophen in it, they need to know not to take other meds that have acetaminophen in it. Because if they start to self-medicate on top of whatever you're giving them, they can get above those limits very, very quickly. Okay, I'll show you an example of that in a second. Another nice thing, this is somewhat relatively new, is there's an IV form called Ofirmiv, and this is actually nice. We give almost every single patient gets surgery at Nemours. We give them a single dose of IV Tylenol, and that's been shown to reduce the opioid needs in the post-operative period. So this is not good for every single patient. And again, I see a lot of people, they're like, well, IV Tylenol, let's give it to everyone. It's also a lot more expensive. I can get, an acetaminophen tablet for cents. This stuff is like $35 a bottle. So you can find that if you're giving several doses to a lot of patients all at once, the cost of it ramps up pretty quickly there. So, sometimes if you ever get calls from the pharmacist, they're like, do they really need IV Tylenol? At least consider, well, maybe they can get a suppository, right? That's not always a bad thing to consider. But very, very good opioid sparing. It's good for patients who cannot get PO or PR Tylenol, right? Also consider, we talked about, in our chemo talks, what type of patients can't get rectal medications? Yeah. Neutropenic patients, right? So this is a good alternative. We have kids who are coming in for hemonc, and they're having these neutropenic fevers. We don't want to give them anything rectally, and they can't take anything orally because they have such bad mucositis from their chemo. We can give them IV Tylenol. It's a great option for them, right? So again, consider the patient case, who's a good candidate for that. So Tylenol, we don't know the full mechanism why it's working, but it tends to work pretty centrally there, which is why it's not a good anti-inflammatory. No anticoagulant effects, which is good. And again, very few cardiovascular, GI, respiratory effects. Very, very safe from that standpoint. However, you need to be careful with the hepatic stuff. So don't exceed 4 grams in a day. If you have patients with existing liver disease, you got to lower that even further. I'd probably even say 3 grams is probably going to be the limit for those patients, right? So again, be very careful with those patients and consider every single source. So if the patient, say for instance, you gave them a prescription, they're taking hydrocodone, acetaminophen, 5-325. 5 is the hydrocodone, 325 is the Tylenol, every 4 hours. On top of that, they're saying, well, my pain's not really that well managed. I'm going to go ahead and just take some Tylenol at home, because maybe they don't understand that acetaminophen is Tylenol, right? Then they start to take 650 Q6 hours on their own. You start to see how that's going to go above 4 grams pretty quickly. And if they're doing that on several days in a row, they can definitely land themselves into some significant hepatotoxicity, right? So again, something you want to consider. Ask what all the sources of Tylenol that they're getting. What are they using over the counter? What are they using prescription-wise, right? Okay. Now with NSAIDs, we mentioned these are good analgesics. They're good antipyretics. They're also good anti-inflammatories, right? They carry some more side effects with them. They're maybe not as well tolerated, but very commonly used. So the main over-the-counter ones are what? Ibuprofen, naproxen, those are the big ones, and aspirin as well. It's going to be the other big over-the-counter one. We have a lot of the prescription-based ones as well. We'll talk about those briefly here. Most of them are going to be non-selective for COX-1 and COX-2, so they tend to have the same GI side effects, the same relative bleeding risk, etc. But we'll talk about some ones that are going to be a little bit more selective, and what are some of the drawbacks and pros to doing that. And again, I'm not going to belabor the mechanism here because we've covered it so many times, but just know by blocking the cycle oxygenase, you're going to be decreasing production of a lot of prostaglandins and other things that are going to be sensitizing those pain fibers. So, as I mentioned, some other ones you're going to run into, things like indomethacin, things like ketorolac, things like tolmetin. Ketorolac, I'll talk about this briefly, is, anyone know the brand name for that? Toradol, right? Toradol is a very good go-to IV NSAID. So majority of patients are coming in for a painful complaint to the ER, probably going to get some Toradol. It's actually found to be almost as strong as some of the weaker opioids from a pain management sort of standpoint, so it's a very good drug there. However, you have to think about things like, well, what's the GI side effects that can run into? And actually, we don't actually give Toradol more than 5 days in a row. And that's actually one of the big things we monitor for to make sure patients don't get too much of it, because if they get too much Toradol, they're going to end up running into that GI toxicity that we worry about, right? What are some other toxicities that you can see for like patients with other organ dysfunction? Maybe not nephrotoxicity in and of itself, but what could it do to the renal function? It can decrease it. Why is that?
Because the prostaglandins.
Yeah, remember the prostaglandins in the afferent arteriole, if they're gone, they're going to cause vasoconstriction. Think about patients with chronic renal disease, how this can then cause a decrease in their creatinine clearance, right? Those are things to consider, right? Typically, if a patient is not responding well to one, you can try switching it up, and within the NSAID class, within 2 to 3 weeks or so. So again, just because they don't respond to one doesn't mean they're not going to respond to any of them, right? So common side effects, we mentioned the gastric and the intestinal ulceration. That's one of the big kind of worrying things we worry about. Bleeding risk is going to be a thing there. And then in some cases, you have to be careful with pregnant patients. And we'll talk about this in OB-GYN later on, but typically NSAIDs are not recommended towards the later stages of pregnancy. Tylenol tends to be pretty safe throughout the pregnancy there, so that's usually the ones we like. The reason for that is that the ductus arteriosus is needed during the intrapartum period to help with the fetal blood flow. Normally when kids are born and they need to start breathing on their own, that ductus arteriosus will close. However, if we were giving them NSAIDs early, that can close prematurely, because guess what keeps it open? Prostaglandins, just like we saw with the afferent arteriole. So if that closes prematurely, that can impede their flow. And in fact, actually what we'll do for kids who have a patent ductus arteriosus after they're born, we'll actually give them IV ibuprofen to try to close that up, right? So we can actually use our drugs to try to kind of monkey with that as needed. Anywho, be careful with patients with a history of asthma. This is not everyone, but some people are going to be more likely to have that thromboxane-induced, or that leukotriene-induced bronchospasm. So you want to be careful they have a history of like aspirin allergy or something like that. And then we mentioned the decreased renal function, right? So again, this is all just kind of common ground we've already tried before. So getting into specific ones, remember aspirin is available over the counter, going to be widely used. Most people are taking how much? Probably just 81 milligrams a day, right? That's not really good analgesic dose. It's really just for cardioprotection from the platelet standpoint. So usually you need more than that, 325, 500, a gram, whatever the case may be. Just remember, side effects can be very nasty with aspirin, much more so than the other NSAIDs, right? Because this can do all kinds of nasty things, which I'm not going to get into. But you develop that salicism, where they can develop this respiratory alkalosis, and they develop metabolic acidosis, and it gets very, very bad. So be very careful. Make sure they do not exceed the normal recommended dosing for aspirin, because they can get into big trouble there, right? Especially if they're taking 81 milligrams on top of it every single day. Sometimes that can get them into trouble. As you mentioned, usually contraindications are mainly the bleeding disorder, but who else should not get aspirin? Kids are post-viral, right? So again, 16 years or younger. Now, does that mean no kid can get aspirin? No, because we give it all the time. We give it for things like cardioprotection for like our cardiac kids. We'll do it for Kawasaki's disease. Like there's different indications for it, but just knowing that post-viral period, no one under 16 should get it because of that Ray's syndrome. Okay, and again, we've covered that, so I'm not going to just kind of put this here for review. So anyway, so getting into the other NSAIDs here, kind of as a structural categorization, we call these the propionic acid derivatives. They kind of all working very similar to one another in that same category there, but they're all NSAIDs. They all work on cyclooxygenase. We've kind of all talked about these already. Used quite frequently for arthritis. So you see, especially with things like rheumatoid or osteoarthritis, NSAIDs get used quite frequently. Myalgias, dysmenorrhea, all these sort of things. We're going to see these being used for the more mild to moderate pains. Now we've seen ibuprofen, we've seen naproxen, but some of the new ones you're going to run into, you may see, include things like ketoprofen, phenoprofen, flurbiprofen, and oxyprosin. Just the differences between them mainly are going to be things like the half-life of the drug. So if you have like really chronic osteoarthritis or chronic rheumatoid arthritis, something with a longer half-life is going to be better. It's going to be able to provide good daily sort of coverage there, right? So that's really the main difference between them. If you think about like the marketing for naproxen or Aleve, what's kind of their tagline? All day strong, all day long, right? So it has a longer half-life than ibuprofen does. And I hate to say that marketing works, but I will remember that till the day I die, probably. but that it shows you it has a longer half-life. They take it less frequently. And again, if you're dealing with this chronic pain, you're dealing with it every single day of your life. You don't want necessarily have to take something every 6 hours, right? It can be problematic. So by using something with longer half-life, better for the more chronic sort of pain issues. For acute pain, something short-acting is probably totally fine, right? Ibuprofen, if you sprain your ankle or if you stub your toe, whatever the case may be, ibuprofen is probably going to be fine for a lot of those cases there. Okay. Now, other ones, indomethacin is the most common thing. I see this, at least from a pediatric standpoint. This used to be used to close those patent ductus arteriosus IV, but you may still see this used on the PO route on the outpatient side. So see some people still using this. But again, large issue of side effects, especially with like ulcers, diarrhea. The bleeding risk is a little bit bigger with indomethacin here, so I don't see it used quite as often. You still may see it used occasionally, but again, shorter term use is better. The more potent of these NSAIDs you have, usually the shorter courses you want, especially that Toradol I mentioned, no more than 5 days, because you're just running that risk of toxicity higher and higher. Toradol, again, this was going to be a workhorse sort of drug. If you work in the ER, everyone's probably going to get some Toradol at some point. And so very, very good, very IV sparing, or I'm sorry, opioid sparing, go-to IV sort of NSAID, very good drug from that standpoint. But because of that, because of the hematologic toxicity and the risk for the GI effects, that's why we limit to more than 5 days. That can actually become a problem too, is when you're looking at a patient, because you have to think about, okay, well, what do they get in the ER? Versus what do they get on the inpatient side? Because you end up finding patients can get too much of it. So because again, you have different providers writing the different orders there, things can get mixed up. So especially if you're working, say, for surgery in the post-operative period, you need to look to see, because if you're writing an order for Toradol, you need to look backwards in time to see, like, what do they already get? Have they already been on 3 days worth of Toradol and I'm writing a new order for 5 days worth? That's no good, right? Because again, every time you have a patient go from that level of care, say from before surgery to after surgery, like you have to readdress all their orders, right? They're getting all new orders whenever they leave surgery. So you have to make sure you're going back and addressing that. And that's something we run into quite frequently, is that people don't look back to see what they've already received to see how much they should be getting. Okay, so you have to call upon that a lot to be like, hey, they already got 3 days worth of Toradol, and we need to shorten up this order just to 2 days, so that way they don't get too much of it. And sometimes the computer systems can help us out, and they can kind of flag you and be like, hey, by the way, they've already gotten this much, but again, can you always rely on the computer system to save you? No, you should not ever rely on the computer system to save you. You got to be the last place that buck goes to, right? Buck stops here. Anyway, another one, Tolmetin, another decent PO NSAID you're going to find out there. Definitely, the more potent of these agents you're going to run into, the more side effects you're going to see. So again, the GI issues, anticoagulant effects are going to be the prominent ones. And again, the anticoagulant effects, are those reversible, irreversible? They're reversible, right? Because again, you're having reversible inhibition of cyclooxygenase. So as soon as the drug's out of the system, the platelets are going to be able to activate again, right? It's not the same as aspirin. Proxycam, another good one. This has a pretty long half-life for the most part, so this is good for osteoarthritis. Decent coverage of therapy throughout the entire day, better for that chronic sort of pain. Meloxicam, this one is actually good because it has some tenfold selectivity for COX-2 enzyme, right? So what's the benefit, do you think, of being more selective for COX-2? So you have less chance of causing those GI ulcers to develop there. Now, ideally, what do you think we should do? Should we have a drug that's completely selective just for COX-2? Why not? Yeah, so, and again, that's not intuitive right off the bat, right? So again, you must have heard about this before, but just off the mechanism, you wouldn't necessarily think about this. So the issue is we did have some completely selective COX-2 inhibitors before. Have you ever heard of Vioxx? Yeah, it's probably beyond most of you guys' time, but there's a drug called Vioxx that was like marketed as like, this is like the NSAID to end all NSAIDs because it's COX-2 selective. This is great, everyone's going to get it. And again, when you're giving, you have these trials for medications, how many people would they oftentimes end up kind of treating just in the clinical trials? Thousands, right? You don't see the things that happen to millions of patients, right? So when this drug came out, it was a blockbuster sort of medication given to millions of people, and they found was there's an increased risk of cardiovascular death. One of the problems you run into is that COX-2 is also helpful for producing angiogenesis. Angiogenesis means what? Making new blood vessels, right? So again, what you're doing is you're impeding blood flow to places like the heart, which, as it turns out, the heart needs a decent amount of blood flow. It needs oxygen, otherwise you're going to have an infarction. So they found was by using a COX-2 selective, I'll get to you in 1 second, by using just a purely COX-2 selective agent, they were causing increased cardiovascular death. So because of that, it got pulled off of the market. So nowadays, we still have a few COX-2 selective drugs, but again, it's relatively selective for COX-2. They'll still affect COX-1, but by being somewhat relatively selective for COX-2, you're getting less of those GI effects, but they've not found any of that increased risk for cardiovascular death. Okay. Yes, ma'am.
For the whole Meloxicam, it says that it's similar to aspirin and Opioids. Is
Mhm.
that just in its effect or also the mechanism?
And it's identical mechanism, right? These all have the identical mechanism, but as in terms of the efficacy of reducing pain, yeah, equipotent there, right? So what you're going to find is we have a couple of drugs that are relatively selective for COX-2. But the question is like, okay, well, which patients do I give which drugs to? Becomes a bit of a quagmire because it's nice for students when they have like, here's a black and white answer. You give this one drug to this patient, you give this drug to this patient. Is it always that easy? Never that easy, right? There's a lot of shades of gray here. So ultimately what it comes down to is you have a patient with a really high risk cardiovascular history, I'm probably going to go err on the side of using something that's going to be non-selective, okay? Because any increased risk, even theoretical, may not be worth it for that patient there, right? If I have a history of a patient with a history of GI ulcers, maybe related to NSAIDs, what am I going to use? Probably something that's going to be more COX-2 selective, right? If I have someone who had both of those histories, what would I do? Maybe don't give them an NSAID, right? Try to find something else, right? So if you can give them an alternative, that's going to be beneficial there, right? But again, it's weighing the risk versus the benefits. Now, there are things I can do for cytoprotection in the GI tract. So remember we talked about GI stuff. We said you can use things like prostaglandin to try to get around there. I can give something like misoprostol to try to replace the prostaglandins I'm not producing and deal with that. That's one way you can get around that, right? You can use non-NSAIDs. You can use other drugs if possible. But in the cardiovascular history, if I hear that, I'm probably not going to want to select a COX-2 selective agent here. Okay. But again, patient with high risk, GI history, this is probably going to be a good drug for those patients. Okay. So ultimately, that's what it kind of boils down to. And if you ask 10 different practitioners and you give them the same patient case, you probably get 10 different answers, right? But it's one of those things. There's more art to medicine than science in a lot of cases. But Meloxicam or Mobic, very very nice agent here. I see a lot of patients who have chronic pain getting started on Meloxicam because it does limit some of that GI toxicity there. That's a good from that standpoint. Another one, nabumetone, some COX-2 selectivity. So again, good for patients with GI history. Good for rheumatoid osteoarthritis. See it used most commonly there. Diclofenac. This one's kind of interesting because it actually has a topical formulation that's available. So if you ever see a Voltaren Gel, that's nice because you can actually just apply it locally. And what's the benefit of doing that? Less systemic toxicity, right? You don't really get a lot of absorption of that stuff. Now, it's interesting here, it's available prescription only, but I remember one time we went on a short cruise and we were in Nassau, and you go to the pharmacy there, you can actually pick it up. So if you want to be internationally muling drugs about, go pick up some Voltaren Gel because this stuff works great. If you have like a nice little, little bit of pain, any kind of soreness, anything like that, just rub some Voltaren Gel. It works great. But some people don't like topical products. Again, they can be, if you get on your clothes or something, it may stain or things like that. Just not as convenient as popping a pill, but it could be beneficial from the systemic sort of standpoint there, right? When it is taken orally, though, you do still run the risk of GI. GI issues, the bleeding, etc. Okay, so again, getting specifically into the COX-2 inhibitors, there's really only one drug that's going to fit into this category that we're going to talk about here that are primarily COX-2 selective. Anyone know what that is? Celebrex, right? So celecoxib is going to be the main one we're going to see here. So again, the reason why we don't like completely selective COX-2 inhibitors is due to that risk for cardiovascular history, stroke, or due to that risk of heart attack, stroke, etc. So that's why they got pulled from the market. So again, most of them got removed, but celecoxib is going to be the biggest one here. Atodolac is another one you may see occasionally. I've seen some vets actually use this for some animals. So if you ever see like a pet who's on it, you may see that occasionally. But celecoxib or Celebrex is the big one. Okay, that's the one you're going to see used most commonly. Patients with GI history, this is a good drug for them. Okay. Again, I'm not going to get specific on here, but just know that as far as like the inhibition goes, it tended to be when you were most selective for it. That's when you end up seeing that risk for cardiovascular history. But because Celebrex has relatively little COX-2 selectivity compared to some of these big ones here, they have not found, at least in studies, that there is a significant cardiovascular risk with it. But if I have a patient who has a recent history of MI, I'm probably still going to be hesitant to give it to that patient there. Okay. Again, if I need to give them an NSAID, I'll probably give them a non-selective one with something for cytoprotection, either omeprazole, or I'm going to give them some prostaglandin or something else. So I try to cause a cytoprotection there. Okay. So those are the anti-inflammatories we're going to cover here. Again, Corticosteroids are going to be used more on a case-by-case basis, right? So depending on if you're dealing with someone like rheumatoid arthritis or something like that, but we'll get into those specific cases later on. But those are kind of the run-of-the-mill analgesics you're going to run into from the NSAID sort of category. Any questions so far? Yes, ma'am.
That's also used on horses and dogs. Is that similar to like Voltaren?
It's probably going to be pretty similar to that if I had to guess. Yeah, but again, I'm not a veterinary pharmacist, so my experience is relatively limited. I had a rotation I did at a Publix one time when I was in school, and we were getting this like dose of or this prescription for Keflex, and I was like, this looks like enough Keflex to like kill a horse. And it was actually for a Burmese mountain dog, so it was not far off from a horse. But I was going to show you, sometimes those things are therapeutically appropriate. But let's go ahead and do a 10-minute break. We'll come back and then get into our opioids. All right, you guys ready?
Yes, sir.
All right. Any questions from the first half? I know that was quick, but I think it was a lot of meds we'd already talked about before, so I didn't want to belabor the points too much. Let's get into the new stuff, because this is very, very important. So, opioids. Are we in an epidemic right now of opioids? Yeah. 100%. It's a big, big problem. But these are very, very good drugs. They're very effective at what they do. So let's talk about them. Let's see how we can use them safely and appropriately. We'll talk about some of the laws around some of these that have changed within the past year or so. So these are either naturally occurring, or we actually have some synthetic versions of these drugs. But the main thing that classifies them as opioids is they interact with the opioid receptors. Okay. Now, we have some natural chemicals that we produce, things like enkephalins and dynorphins and things like that. They can interact with our own opioid receptors, natural analgesics that we produce. But the main ones you run into is mu, kappa, and delta. Sometimes you see this is OP1, 2, or 3. For our purposes, we're mainly going to focus on the mu receptors. Okay, these are responsible for the primary analgesic effects, the primary euphoric effects, and the primary negative effects, the side effects we're going to talk about. Kappa and delta are also very important, but for our purposes, I don't got time to talk about mu right now, because that's the primary thing that we care about. Good for moderate and severe pain. Okay, so again, if you stub your toe, you're not going to get morphine for that, right? If you break your femur, you're probably going to get something, right? Anyway, anyone know what kind of plant that is? The poppy plant, absolutely, which is why if you were to eat a whole bunch of bagels, say with a ton of poppy seeds, what could you show positive for? For opioids. You need a lot of poppy seeds, right? So that excuse is pretty poor. And in fact, actually, when you get a urine drug screen done, say like for a job, for employment, once they get positive opioid screen, they would then do confirmatory testing with like a gas chromatograph, things like that. They know if it's poppy seeds or not. So if you're still positive, like they know what's up, right? Anyway. But this is the poppy plant, so this is the original place where we got all of our opioids from. This includes things like heroin. Heroin comes from this plant. Codeine, morphine. These are what we call our natural opioids. These are the kind of the first ones we had for a good long time. Now, the way these are working, these are not anti-inflammatory. These are purely analgesic, right? So if I have pain that's coming in from the peripheral nervous system, that signal is going to get transmitted through the spinal cord. There's opioid receptors here that are going to be interacting with the drugs. They're going to help to blunt that signal from making it up to the brain. And then there's going to be signals or receptors here that are going to be also affected by the opioids, right? This is where you're going to see a lot of like the euphoric effects. This is where you're going to see a lot of the respiratory depressant effects, etc., that happen here centrally. But a lot of the analgesia actually is in the spinal cord. It's where you get the primary amount of analgesia from those drugs, right? And again, someone had described it to me because I've never really been on. I think I had my wisdom teeth out when I was very young, and I think they gave me like Darvocet, which is like, when I think back on it, I was like, that's like the wimpiest one. Like, you couldn't give me something better than that. But so I've never had too much experience with opioids, but someone had described it to me. It's like you still know you're having pain, you just don't really care about it so much, right? So you're blunting that signal. It doesn't get rid of it completely. You just don't really care so much about it, right? Very good as analgesics, though. So we mentioned mu is the primary one we're going to be focusing on here. This is responsible for the analgesia, the euphoria, the respiratory depression. These are the primary effects we care about when giving opioids to our patients. Now, it's not to say that kappa and delta are not important, because they do have their own effects here as well. But again, let's focus on the mu effects. It's the primary thing we care about. So their mechanism of action, we're going to find that some of these can be an agonist. They can be a full agonist at the receptor. There's some that are going to be partial agonists. You can even get more complicated. You can have an agonist-antagonist sort of effect. We're not going to talk about that so much. But then, very importantly, we're going to talk about an antagonist. Why is an antagonist at the mu receptor so important? If you have someone who overdoses on it, or if you have someone you need to reverse out of that opioid effect very quickly. So we're going to talk about that. Anyone know the drug we use for that? Narcan. Everyone knows about Narcan. Fantastic. Good. Agonists are the most commonly used ones we're going to see. Yes, ma'am.
I got article pop-up thing notification from Medscape saying, I think it was Medscape, saying that they're gonna make over-the-counter Narcan.
That's the thing they're trying to do. Yeah,
That's crazy.
it's not crazy. I mean,
Well, I guess it's not crazy, but like.
it's a sticky wicket, right? It's
We
a
have to do that.
yeah, it is unfortunate we have to do that for sure, right? But again, the opioid epidemic is such a problem that it's kind of necessary. Now, in fact, there's a blanket basically prescription from the state attorney general, not attorney general, the surgeon general, thank you, that says, listen, you just have a blanket order saying like you can go get naloxone as a healthcare provider, you can go get naloxone from the pharmacy. And have it available to me, especially like EMT and things like that, because having it available can absolutely save a life. So
meaning like at the PA, you can have it on you, and then
yeah, you can go in.
Someone on the floor.
Nurses, PAs, docs, pharmacists, anyone could go and get some, right? Not all the pharmacies know about that yet, but it's one of the things that is in the law, right? So, anyway, so we'll talk about that a little bit later on because there's really some issues with it. But for our purposes, for analgesia, agonists are going to be most commonly used here. So, looking at some of the terms here, so the terminology is very, very important because I think as people who may not have experience with some of these patients, it's easy to kind of lump people into the wrong categories here. So, there's 4 things I want to talk about. One's called physical dependence. There's addiction, there's tolerance, and pseudo addiction. Okay, so we're going to talk about these briefly here. But when I say physical dependence, what does that mean? Your body is used to having that around, right? So if I'm taking oxycodone every single day, that becomes my new normal, right? That becomes my homeostatic thermostat has now been set to have opioids around all the time. That means that when I come off of the drug abruptly, what can happen? Withdrawal, okay? Does someone coming into the ER with withdrawal mean that they are addicted to opioids? No, it just means they're physically dependent on the opioids, okay? Because someone can have physical dependence and not be addicted. All right, that's not the synonymous sort of terms there, okay? What is addiction? When you are, despite the negative consequences, you're still going out of your way to get those medications, right? So again, if I have to make the decision between getting my opioid, my heroin, or feeding my children, and I decide I'm going to go get the heroin, that is addiction, right? Or if I know that I'm going to lose my job because I'm zonked out on heroin, and I still make the decision to do it, that's addiction, right? So again, that's a clear delineation between those two, those negative consequences that you're taking on, despite the fact that you know it's going to happen. That's considered addiction there, right? Tolerance is what? Exactly right. So remember, we talked about tachyphylaxis, where it's one of those phenomenons where even though you're increasing the dose, you don't get any additional effect. You don't really see that with the opioids. You're going to find people who will be on a single dose of an opioid, and again, this is more chronic pain we're talking about this. Say they're on 10 milligrams of OxyContin twice a day, and all of a sudden they're like, oh, my pain's just not really being that well managed. And it's, I need a bigger dose. Does that mean they're addicted? No, it could be the tolerance there. You get tolerant to the analgesic effects. And so you can find these little old ladies with chronic cancer pain who are on extraordinary amounts of opioids. If you were to give it to someone who's opioid naive, they'd be dead, right? And we've seen cases of that where you'd have like a grandkid going through grandma's medicine cabinet and say, oh, look, grandma's on MS Contin, this long-acting morphine. They're on 120 milligrams. I'm going to take one of these. She's 90 years old. There's no way that drug can affect me, a healthy 18-year-old. No problem, right? And they die, right? Because of the fact that they're not tolerant to those effects, but certainly the grandma is, okay? You need to be really careful with those. What's pseudo-addiction, do you think? Exactly right. So if you had someone coming into the ER and they say, "Oh man, I ran out of my opioids. I need some more." What does that sound like? Yeah, it sounds like drug seeker. It sounds like they were using it too quickly. Well, what if their pain was never appropriately managed in the first place? You give them one dose of an opioid, but it really wasn't enough, or they've become tolerant and they need more, and so they started self-medicating to try to handle their pain, and now they ran out early. That's considered pseudo-addiction. Now, is that easy to discern between pseudo-addiction and regular addiction? It is almost impossible, right? It's very, very difficult to determine that. And so, again, that's where you as a clinician have to be using your noodle, right? You have to be thinking about, okay, what's the history? What's going on with these patients? And using your tools that are available to you. And so, again, I don't know if I mentioned it, but there was a case where we had this lady who was basically in the PDR for this pain associated with these kidney stones. And so I came in, I was doing my shift, and I see this, lady who is obviously, if you see a 40 or 50-year-old in the PZR, okay, something happened here, this is not right here. And so she was getting a second dose of Dilaudid. Dilaudid's an opioid we're going to talk about in a second. I'm like, why in the heck is this lady here getting these opioids? And normally our process is if an adult comes into the ER, we will get them stabilized and we'll ship them off into an adult ER, right? So they're waiting that transfer, she's still in pains, they're giving another dose. And so I was looking at the chart and everything, and I was like, it's kind of weird. It's like the second time she'd done this. And so, of course, the guy managing is a peds ER doc. So again, he's used to dealing with kids, right? He's not used to dealing with adults. And so I was like, that's really interesting. You know, it's not normal we get an adult like this with these complaints. You know, I was like, let me look up her profile, right? And so we have something called E-Force. You guys have heard of E-Force before? It's something you guys now have to look at whenever you're prescribing opioids to patients, and I'll talk about it in a second. But basically, it's a statewide database where I can put in the patient's information and find every single controlled substance prescription they've picked up since E4 started, basically. And so I'm going to look up this lady real quick, because as a healthcare provider, it's within my purview to make sure that when we're giving this lady opioids, it is therapeutically appropriate. So I said, let me look this up. And go through and look at it, and sure enough, the lady had like 14 different addresses and been filling oxycodone, hydrocodone, Dilaudid, all these different pharmacies all over the state. I was like, huh, this seems a little fishy. The history did not match up. So I went over to the doc and I was like, hey, why don't you take a look at this? He's like, oh, I can't believe it. I was like, well, and he's like, well, but she seemed like she was in a lot of pain. I was like, yep, they can get pretty good at faking that sort of thing. He's like, oh, I'm not giving her anything else. And I was like, all right, that works. So it's one of those things where, again, using the tool, and again, you can make a print out of it and take it over to him and say, hey, what's up with this? Like, you just filled 100 Percocet 2 days ago. Where'd all those go? Why are you here at the ER? But it can be a very helpful tool to be like, hey, what's going on here, right? So, and again, not to say that every single patient is going to be fishy like that, but it helps to do your homework, right, and actually find out. You know, people will do things like they'll prick their finger and put blood into their urine to try to make it look like a UA that has positive blood in it, right? It's more consistent with having kidney stones to go along with the pain that they're faking, right? So again, these are things that they will do to try to get subvert the system.
So is E4 something which only pharmacists can access? Or
Nope, every healthcare provider. So when you get your license, you will be able to sign up for eForce, and actually a lot of places now are mandating, and the law has now changed to mandate that you have to look it up anytime you're writing for a controlled substance.
We have a similar thing in Georgia, but what happens is like CVS, Walgreens, they will
Mhm.
do it, but like the mom and pop pharmacies, they won't.
Right, and so here in Florida, the pharmacies are mandated to report that to eForce.
So all pharmacies.
All pharmacies are gonna have to do it, right? So, and again, most people are gonna go to the big chains, things like that, you know. But yeah, that's one of the mandates there, right? So you as a provider, you don't have to do anything. You can just go to the thing and look it up and find the history. But again, that's all the information coming from the pharmacies. That can be a very handy tool. But anyway, that's now a mandate. Now that we'll talk about the bill a little bit later on. But anyway, so again, these are different things, right? So again, just because you have someone who is addicted or who is very tolerant and physically dependent on opioids does not equal addiction, right? So that's one of the main misnomers I want people to make a difference. I was grading some grad projects, and someone was doing a project on opioid addiction, the opioid epidemic. They kept saying these addicts, these addicts, these addicts. I was like, it's not the right nomenclature, right? Because again, once you lump people into that category, guess what? They're always going to be an addict from now on, right? And you want to be able to keep that separate in your mind. Be like, they have a substance abuse problem, but they're not an addict, right? You know, they are addicted to the medication, but they're not an addict. And so again, I just want you to think about like the person behind some of these the labels these people get ascribed to them, because a lot of times it may not be their fault, right? They have an injury, so they're taking these opioids, all of a sudden they're physically dependent, and now no one wants to give them any more meds because they said, well, you should be fine now. Not taking into account they may have actual chronic pain issues, and then now all of a sudden they're having to go through subversive means in order to get more medications because they're still having a lot of pain. Right, so again, this is something you have to really think about and make sure you don't just kind of blanket lump everyone into that thing, because everyone probably knows that ER doc that's just like, oh, they're drug seeking, I'm not going to give them anything. That's not always the most appropriate thing to tack to take with those patients. Anywho, too many tangents. So as I mentioned, physical dependence is a expected and common occurrence. We know if you're going to be on opioids, any person on opioids for a long period of time, you're going to become physically dependent to those medications. That is your new normal. How do you get off those medications? Slowly, you got to taper, right? So you always got to build in these tapers, and we'll have kids in the ICU who have been they've been ventilated on, been intubated for say weeks, and they've been on opioids that entire time. We have to wean them off of it because we know they're physically dependent, right? They're going to have withdrawal phenomena if we don't. Now, looking at withdrawal, how does that manifest? Sweating, nausea, vomiting, tremor. They're very cranky, especially if you put them into withdrawal. We'll talk about how you do that in a little bit. Not great. They're going to feel like they want to die. It's not fatal though. And we'll talk about some meds later on that when you withdraw from, they can be fatal due to seizures and whatnot. But this is going to be one of those things where they're going to be really miserable, but no one's going to die from this, right? But something you definitely want to avoid, especially in patients who have a substance abuse problem or something like that, because when you start to withdraw like that, what do you want to do? You will do anything to get those meds back so you do not feel that bad, right? So again, it's one of those things where they may be presenting to the ER because they're withdrawing. They just need something to like try to get them stable, right? Because again, they're going to feel really miserable from that. So again, something you want to be careful of. But again, not necessarily correlated with addiction. Not every single person will become addicted to these medications, but every single person will become physically dependent, okay? Now, why do people get addicted? I don't know, like it could be the genetics, it could be their psychosocial history, it could be a million different factors there. We just know some people tend to be more likely to become addicted, maybe due to the pharmacogenetic differences. It all has to do with that dopamine pathway, that reward pathway. So just like eating a juicy hamburger or having sex or getting 100 on your test, that's that dopamine squirt, right? It's that positive reinforcement. Same thing happens here. Some people are more susceptible to that from opioids than others. Okay, so again, it's one of the things that is not necessarily going to happen, but can happen. Okay. And I mentioned that tolerance. Now, patients will get tolerant to the analgesic effects. Doesn't mean they're always going to get tolerant to all of the side effects, okay? So that means that, for instance, like constipation is one of the most common side effects you're going to run into with opioids. They're always going to have that. They never really get tolerant to that effect there. So again, patients on opioids, they're going to get stopped up no matter what. It's never necessarily going to get better, right? Then we're going to talk about bowel regimens and stuff a little bit later. Now, there's something called pseudotolerance where it could be are not actually tolerant to the analgesic effects, but maybe their pain has actually gotten worse. So maybe their injury got worse, or they're being more active, or something like that. That is considered a pseudotolerance. That happens with a change in pain state, not necessarily a change in how they're responding to the med. And then we mentioned pseudo addiction, not to be confused with actual addiction, but their behaviors appear to be consistent with that. But a lot of times it's due to maybe not being appropriately managed in the first place, right? Either the duration wasn't long enough, or they did not get enough meds for their level of pain, whatever the case may be. Okay, so again, when looking at this, is it addiction or appropriate use? Usually addicted individuals lose function, right? So they can't maintain a job, they're not feeding their family, there lots of different things like that. Typically non-addicted individuals, when they actually get appropriately managed, they end up gaining function, right? So again, their pain's managed so they can actually go out and play with their kids, or they can go out and go to their job, or whatever the case may be. That's typically the difference between these two, but it's still very difficult to determine. And physical dependence is always going to be expected there. And as I mentioned, incidence of addiction, I don't know, like could depend on the population you're dealing with, could depend on a million different factors. So this is example what the E4 thing looks like. As soon as you get a license, you're going to have the ability to look at this. They're starting to build it into a lot of the electronic medical record systems, which is nice. That way you can automatically just pull it up whenever you're looking at a patient's chart, which is very beneficial. But this will tell you all of the controlled substances that patient's been filling at pharmacies within Florida. It does not go across state lines. So if they decide to go across the border to Georgia and they want to pick up a bunch of meds, we would not know about that. This is only for Florida. But at least in Orlando, if you stay in this area, like people are less likely to have traveled to Georgia necessarily. But if you work up in Jacksonville, that's a pretty quick drive, right? You can make it over to Georgia, no problem. So it just depends, right? And then we ever heard of the OxyContin Express? Yeah, so the OxyContin Express is like basically Florida is like where it originated. Basically, you'd have people coming from like West Virginia and Kentucky and stuff, and they would drive down by the busload down to Florida. We'd have all these pill mills that were available here. We'd have these practitioners, we'd have pharmacists, we'd have docs, and everyone who were basically in cahoots in filling all these really kind of bogus prescriptions. They'd be getting hundreds and hundreds of OxyContin, Percocet, all these things, and they would travel back up to Kentucky, West Virginia, and then be able to distribute it out there. So this is where you see a lot of opioid problems come about. And for a long time, we saw that prescription opioids were the biggest problem here in Florida, right? Now that the laws have changed, we shut down a ton of those pill mills. We got rid of a lot of those bad practitioners, and they sent them to jail. Now we're starting to see that what's starting to become more popular. It's not prescription. We got non-prescription stuff, and that mainly is heroin, right? Because again, all these people are still addicted. We're still here. So now we're starting to see a lot more heroin. What's the problem with heroin? We have no idea what the heck's in it, right? So for instance, at least if I got a pill of oxycodone, and I get it identified as correctly as oxycodone, I pretty much know what's in that, right? It's hard to kind of fake that sort of thing. Heroin, though, if I just get this white powder, I don't know what's in there. And actually, one of the big problems we're running into is starting to be laced with other opioids, things like fentanyl. So if you ever hear about fentanyl becoming a big problem in heroin, that's what we're talking about. And I'll kind of mention why that's such a big issue in just a few minutes here. But make sure you're checking this out. And again, people's heroin purchasing history, not going to be on eForce, unfortunately, but trying to get the drug dealers roped into reporting, but they don't do that yet. But in pharmacies, absolutely will be on there. I don't know enough about the Silk Road to speak to that, but it's kind of like the internet, like using like the dark web to spread the stuff around. I imagine it's still pretty prevalent if I had to guess. But yeah, I don't know how much of that actually factors into it. Normally, what I find, at least for a lot of patients like who overdose and present to the ER, like normally they just bought it from someone around in the community or something like that. So that's a good question though. If you need someone murdered, like you always use that too, right? So the other big thing, hire a hitman off the Silk Road. Not that I would know about that. It's crazy. Anyway, so House Bill 21 was the big change that happened in July of last year, right? So it's hard to believe it's already 2019, but went into effect in July 2018. This applied to any controlled substance prescribed in Florida. Basically, what it said is that practitioners who are going to be prescribing them, which now can be you, right? Include a 2-hour training course. You have to take a specific training course on the safe and appropriate prescription of controlled substances, and then also you have to check E-Force prior to prescribing. Okay? Yes, ma'am.
Include not just like controlled substances, like for example class 2, but also like behind the counter medications?
It does not apply to Sudafed because again you can get that without a prescription, right? This only applies to things that you're going to be prescribing.
So this is just prescription medication.
Right, but this includes like your Adderalls, like things for ADHD. This includes things like for seizures, who may be controlled substances. This includes any controlled substance. So again, it's pretty wide range, but the more common one you're going to run into is probably going to be the opioids there, right? The other big thing, the other big difference here, and this is going to be the prescribing for pain issues, is that unless otherwise stated, it's assumed these prescriptions are going to be for acute pain issues. And you can only write for a max of 3 days, typically. Now you can write for acute pain exemption and extend that up to 7, but you actually have to physically write that on the prescription, okay? One of the things we'll see with the C2 medications, they have to be on a actual prescription. They can't be faxed in, they can't be anything. You have to actually hand sign it on paper, right? There's starting to be some things where you can maybe send it electronically, but that's we're still trying to figure that out. But typically, these controlled substances, these C2 medications, have to be on paper, and they have to say acute pain exemption if you want to give it more than 3 days. If you don't write that and you wrote for 10 days worth, guess what? Pharmacist is going to call you up and be like, this prescription's no good, or they're just going to hand it back to the patient and say, I can't fill this. What do you think it's going to do to your patient satisfaction? It's not going to be great, right? So again, you have to be careful with this because if you write for more than that, then it's going to be an issue. Okay. For chronic pain, you have to actually physically write on there non-acute pain. So that way the pharmacist will know that, okay, this is a chronic pain issue. Hopefully that patient is known to the pharmacist, and that's one of the problems we find. I've talked to patients before with chronic pain issues that they'll go to a new pharmacy and they'll be like, I don't want to fill this. This is for way too much this medication. I don't know you. This is not appropriate. Because I've had some weird people walk up with prescription for 200 OxyContin and be like, here you go, and I'm like, the dude just looks sketchy as all get out, right? Like it's just like there's no way this looks legitimate. And again, it's within my right as a pharmacist. I can say I'm not going to fill that. That's totally. I can hand it back to him and say I'm just not going to do it. That's within my right, right? Just like it's your right to not prescribe anything at all. So, but by writing the non-acute pain, that will lift you from that 7-day exemption, that 3-day exemption, to say, okay, you can write for a month's worth if you want for these chronic pain meds. But again, it should be therapeutically appropriate. And again, hopefully these patients will be able to find the pharmacy that can fill it for them.
You guys have pain management contracts?
We don't do contracts necessarily. There are pain management clinics that pharmacists work at where they'll do contracts with patients. But can you kind of speak to that? Because I don't know if everyone knows about that.
Because back in Nevada, they have pain management contracts where if you go to a pain management doctor, they have specialties. The patient signs a contract so that if they do have an acute pain and you look up we call it PMP in Nevada, you look that up and you can see that they have a contract. You as a provider can say you need to talk to your pain management doctor and they can adjust your pain management, but I will not prescribe to you.
Yeah, so that can be pretty tough. Yes, ma'am.
I went to the other year and they wouldn't prescribe for anyone that's
Yeah, so again, that could be important because like, why aren't you going to that person, right? Like, what are you doing here for that? Yeah, so pain management contracts can be very important sort of thing that you set up with the patient there. They can include things like drug testing oftentimes. So for instance, I remember one time they said, we got to test to make sure that they're positive for hydrocodone. Like the patient was being prescribed hydrocodone. I was like, why are you testing to make sure they're positive? To make sure they're actually taking it, right? Not selling it off to someone else. And they came back negative, and they know that they were probably selling it for something else, and then they kicked them out of the practice, right? So again, it gets a little bit more complicated. But anyway, so again, these are the new restrictions now. So again, if you're working in the ER, you can only write for those 3 days. And again, that's pretty safe practice for the most part. Again, if they need something longer than that, they probably need to be seeing someone else than just the ER provider, right? So that's something to consider. So, and again, looking at the scheduling, what's the C1 mean? Anyone remember? Talked about this briefly before. It's a Schedule 1 substance. You can, yeah, it is. It's considered to have no acceptable medical use. Cannot write for it. And high abuse potential. Okay, that's what the C1 means. So again, what's an example of a C1? Marijuana federally is still considered a C1. Now we're starting to relax that in a lot of states, and so for instance, here it is allowed for medical use, right? What else? Cocaine's actually a C2. So what's the difference between a C1 and a C2? There's an acceptable medical use, but still has a very high abuse potential, right? So C1 and C2 have the same abuse potential, but what the delineation is whether or not it has an acceptable medical use, right? So for instance, if you're looking at cocaine, you can use that for like ENT procedures. It's a good anesthetic. It's a good vasoconstrictor. There's uses for it, right? For instance, with your amphetamines, all of your amphetamines used for ADHD are C2s, right? Methamphetamine, though, crystal meth, does not have an acceptable medical use. So that is a C1, okay? And again, think about the federal versus state levels. They can dictate what those, what schedules those are. Which one do you follow? If, say, for instance, like Florida has this as a C3, but then federally the drug is a C2. You followed the more strict one, right? So again, if it's more strict, now marijuana is kind of a weird one because again, federally, it is still illegal to have that substance because it's a Schedule 1 substance. However, you can go to Washington D.C. and get a green card and have marijuana at the, right in front of the White House if you wanted to. But it's weird. Marijuana is a weird one, okay? So we can talk about that more later. But that's mainly the difference there. Now there's C3 through 5, which have, de-escalating amounts of abuse potential and acceptable medical uses. The majority of the the opioids we're going to talk about here are going to be C2s, okay? Hydrocodone used to be a C3, but that got bumped up because of the abuse potential of it. People were abusing it quite frequently. And again, how do we dictate what the abuse potential of it is? I don't know, like we go off the clinical trials, we go off of the actual, like what we're seeing out there in actual clinical, in the real world. And so we saw that a lot of people were abusing hydrocodone because it had less restrictions on it than something like oxycodone, and we bumped it up to a C2, okay? Who makes those decisions? Could be lawmakers, it could be, usually the DEA has a role to play with that because the DEA ultimately is the one that enforces this stuff, right? Okay. Anyway, so getting into the specific drugs here. So we have things like codeine, Tylenol number 3. This is the wimpiest of the opioids that we have. This is usually a C5, right? So again, very, very wimpy from that standpoint. We don't frequently use it anymore, especially in pediatrics, mainly because of the fact that for it to work, it has to be converted to morphine. That happens through the enzyme CYP2D6. If you have a lot of that enzyme, great for you because you can convert a lot of it over to morphine, unless you have things like obstructive sleep apnea. We had some kids that have actually died from that because, again, they were post-op. Their throat was swollen, they had OSA to begin with, they end up having respiratory depression and seen with that. So we don't like to use codeine anymore. If you had very little of that enzyme, then it didn't really work too well for you. So because of that pharmacogenetic variability, it's not great. So we don't really use it too frequently anymore, especially in pediatrics. Some may see it used occasionally out there. And again, be very careful of that black box warning with the patients who have a lot of CYP2D6. They metabolize a lot of that to morphine. They're more likely to see the respiratory depressant effect seen with opioids. Okay, so be careful with that. Typically, patients of Middle Eastern or African descent tend to be more likely to express that. Now, morphine is a tried and true workhorse sort of opioid. Again, this is still considered what we call like a natural opioid because it's very structurally similar to heroin and codeine and what we get from the poppy plant itself. There's a lot of different formulations. IV is very commonly used. PO, we have immediate release, extended release preparations, a lot of different varieties that are out there, okay? And just know that there's a few different metabolites that are formed from this when you metabolize it within the liver. One of the things you're going to find is this morphine 6-glucuronide is actually metabolized from morphine and actually has even greater analgesic properties than morphine itself and is renally eliminated. The problem is if you have an elderly patient who has bad kidney function, guess what? They're going to hold on to all this. Guess what? Now they're getting over-medicated even though the dose of morphine looks okay, right? Because they have the active metabolite building up. So you got to watch renal function in these elderly patients with this, okay? Other thing with morphine is you get a lot of histamine release. So people taking morphine or codeine, because again, codeine gets turned into morphine, they can get itchy, they can get rashes, they can get some hypotension in some cases. So how do we treat that, you think? Give them some Benadryl, right? Now, is that considered like a true allergy? No, it's a drug intolerance, right? I can switch them over to something else. I'm not worried about having a cross reaction there. That's directly related to histamine release, and that's the worst with morphine. So just make note of that one, okay? So someone says, they have a morphine allergy, ask about what it was. If they say, oh, I got really itchy, got some rash, like that's probably going to be more related to histamine release, okay? Next we have hydrocodone. This is primarily just found with acetaminophen, primarily found just via the oral route. There's actually a form by itself. There's a new one called Hydro ER, and I mean you can just get like just huge doses. Be very careful with these extended release preparations of like some of these drugs here, because they should really only be used for chronic pain management, not for acute pain management. But hydrocodone, very commonly, this used to be I don't know if it still is anymore, but the #1 prescribed medication in the U.S. because it was such a good analgesic. And so acetaminophen, hydrocodone was like just the #1. That probably has changed a little bit since it got bumped up to a C2, so the restrictions on it are a little bit heavier, but very commonly used here. It's interesting, this one's actually metabolized over to hydromorphone or Dilaudid via that same CYP2D6 sort of metabolism here, which means some people who are ultra rapid metabolizers may have a little bit better efficacy here. People who are poor metabolizers may have a little less efficacy with that one. This is less clinically important than codeine. So we still use hydrocodone in the majority of patients here, okay? And again, it got bumped up to C2, so the restrictions are a little bit heavier on this. You may still see this used as a cough suppressant. So there's a product called Tussinex. It's a liquid formulation that we can also use as well. It's another opioid action on the mu receptors. It's a cough suppressant. And in fact, if you remember, what cough suppressants have we talked about previously? Robitussin, which is otherwise known as dextromethorphan. Dextromethorphan is actually structurally similar to opioids, but it does not cause opioid effects. It doesn't interact with those mu receptors, but it still causes antitussive effects, and kind of think about those similarly. Next we have oxycodone, good old oxy, tried and true. Very potent, actually twice as potent as oral morphine there, and available in a lot of different forms. If you hear of Oxycontin, that's the extended release preparation. In fact, this has been pretty prominent in the news. There's been a lot of issues around that where the original makers of Oxycontin have been getting in some legal trouble because they've been either pushing docs to prescribe it too much. There's a really interesting documentary about this, and when they came out with it, they originally said, look, you only have to give Oxycontin twice a day dosing. And that was beneficial from a compliance standpoint, from a patient satisfaction standpoint. The actual studies really show that you probably should be taking it every 8 hours, not every 12. But the marketing was like, no, we got to do every 12. That's going to be our key to success here. And so what do you think happens if you're underdosing patients on these opioids? Pain management is not really well tolerated, so what are they going to do? Start self-medicating, take more of it. Guess what happens at that point? They become addicted. So a lot of patients are becoming addicted to these to oxycodone specifically, and so there's starting to be some big legal ramifications for those people there that were either prescribing it incorrectly or pushing prescribers to do so incorrectly. So that's kind of interesting things you see out there in the news now. Anyway, oftentimes it can be found with acetaminophen as well. So if you see Roxycet or Percocet, usually if you see that set in the name, that CET, that's acetaminophen is what they're talking about with that one. This one often is metabolized over to oxymorphone. This is another opioid we're going to see in just a little bit. So again, CYP2D6 metabolism, so be cautious with that in those patients as well. Same mechanism as the codeine, but again, less clinically significant. Next we have hydromorphone or Dilaudid. This is a very good either oral or IV sort of agent here. Now when you're talking about cross-reactivity with opioids, if you have someone who has a true blue morphine allergy, the question is, well, what opioids can I use for those patients? The more synthetic you get, the more kind of structurally dissimilar you are from the original morphine, the more likely you are to have, or less likely you are to have an actual cross-reactivity there. So if that's something that doesn't look anything like morphine, the less likely I am to have a cross-reactivity. Does that kind of make sense? Because again, your body's responding to the structure. You've developed antigens against, or antibodies against that structure. Dilaudid is starting to get to that point where we're getting dissimilar enough where I can actually use it in some of these patients here. So if they have a history of morphine allergy, potentially they can receive hydromorphone as an alternative. And so we'll use that. Or if they have a lot of histamine releasing with morphine, we'll give them hydromorphone as an alternative. And we use this a lot, especially with our sickle cell kids and whatnot. A lot less histamine release and a lot of growing use. See a lot of our anesthesiologists are using this in the direct post-op period. I'm seeing this used a lot for, as I mentioned, sickle cell kids. Again, to be very popular. So, and again, if you ever have a patient come up and say, I want my Dilaudid, Dilaudid is what they're trying to say. Anyway, up next, this is a very interesting one here. It's going to be fentanyl. Sublimase, there's a bunch of different brain. There's actually a ton of different formulations that are out there. IV is probably the one you're going to use most frequently, but there's transdermal products. There are transmucosal products. That's actually the fentanyl lollipop. Anyone see any issues with that? Perhaps if a kids around their grandparents, someone that has the fentanyl lollipop, they're, oh, this looks delicious, and then they're passed out and dead, right? So typically, if you're using this IV, good for acute pain management in the hospital sort of setting. Any of these dosage forms need to be for chronic pain management, right? Because again, you're going to find that these have it's a very potent drug. needs to be in these long-acting formulations, like the transdermal formulation. So if you see something like on a fentanyl patch, something like that. The patches you have to be really careful with, because one of the things, if you think about someone who's like a chronic back pain, like what's something that's like non-pharmacologic you'd use to help with chronic back pain, you think? Heat. Interesting. Well, what if someone had heat on top of a fentanyl patch? Increases the release, the dissipation. You've seen patients die from that. Either someone who went, say, got into the jacuzzi, all that heat caused the drug to be released much quicker. Seen some patients try to commit suicide doing that. Would actually like put a blow dryer, put a bunch of fentanyl patches on, took a blow dryer, try to kill themselves that way. Lots of weird things. So be careful of those patches and heat. You don't want those two to mix. The other thing is that when you take a patch off, is all the drug gone? No, because what drives the drug into the skin? Concentration gradient. So there's still a lot of drug left on those things. So who could that be a problem for? Kids get into it, right? So kids eat a patch, or pets, right? Those are the big things. So be really careful. Make sure that's when it's being discarded, that it's not in a recoverable form where someone can get into that, right? So as I mentioned, long-acting form is good for chronic pain. IV used all the time for acute pain. There's a couple of cousins here of fentanyl. My dad's a nurse anesthetist, and so he always talked about fentanyl and fentanyl's brothers and sisters. So I talked about Remy, Al, and Sue. He's about as nerdy as I am, so there you go. There's alfentanil, sufentanil, and remifentanil. These are used in the surgical settings quite frequently. We use a lot of like sufentanil drips. That's probably the most common one we use for some of our cardiac kids. So if you work in surgery, you'll get very familiar with fentanyl and the cousins there. And this is good because this is a fully synthetic opioid. So if you have someone who has a true morphine allergy, or maybe say a hydrocodone allergy, this is a very good alternative agent you can use. You can use this, and there should be no cross-reactivity. Because if you look structurally at them, and again, I didn't want to bore you with that, you're going to find they're very different looking from one another, which is good. Still interact with the same mu receptor, it just doesn't cause any cross-reactivity because they look so different. Methadone is another one here. What is methadone normally used for? Anyone know? Usually for patients with opioid addiction, to try to help them titrate off of the drug, right? So basically switch them from their opioid du jour and then slowly titrate them off over the long period of time. Now, nowadays, what you actually find is that this is also being used for chronic pain management as well. It's actually a really good drug because if you think about something to try to hopefully stave off withdrawal, what sort of pharmacokinetic principles would you want to, or what would make it an attractive candidate? Maybe partial agonist, we'll talk about that in a second. Long duration of action, long half-life, right? Because again, if you think about it, if you're going to the methadone clinic, it's only open on the weekdays. Monday, Tuesday, Wednesday, Thursday, Friday. Remember, you build up a big dose of the drug in the body. The weekend's closed, so you go over the weekend. Guess where everyone's at Monday morning? Well, I tell you what, they're right there at the methadone clinic, ready to go, banging on the door, right? Because now all of a sudden their levels have dropped to the point where they are worried about withdrawing, or they've maybe started to have the early signs of withdrawal, and they get that next dose on that Monday. But that's the benefit there, the long half-life. Even if they go cold turkey, you're going to find that's going to be sticking around for a while, right? And that's going to be an important principle. We talk about like some psych meds as well later on. But very long half-life from that standpoint, which also makes it good from a chronic pain management sort of standpoint as well. So that way I can give it one time a day and it has good 24-hour coverage for those patients there, okay? Now, one thing I will tell you, anytime a patient comes in, and this is probably going to change a little bit now that E-Force is more prominent, but anytime a patient comes in and said they're on methadone, you ask them what their dose is, half it. I've seen some issues where just like, they tell you how much they drink, what do you do with that number? Usually double it, right? Or how much they smoke, usually double it. So it's one of those things where patients can sometimes be a little disingenuous. And I had cases where this happened at ORMC. I think one time my wife was working there, where a patient came in with on methadone. They have a program there. I think did you say your husband does that? The farm tech. Yeah, so you may have even heard of this case where basically a patient came in, said, the pharmacy techs will do the med history, patient's in the ER, they'll present that to the pharmacist will look through, make sure it looks okay, verify, and then when you're admitting the patient, the provider will go through and say, okay, this looks all good, let me reorder, okay. Normal process. This patient came in and said, oh, I'm on this dose of methadone. It sounded high, but it was not an unusual dose, because remember, you can take very high doses of opioids because of the tolerance. They said, okay, I'm on this dose of methadone. So the tech said, okay, sounds good. Took it to the pharmacist. Pharmacist says, sounds reasonable. Okay, sounds good. And then the doctor ended up ordering it. Well, the patient was lying. No one ever bothered to double check with the methadone clinic. And so next morning, the patient was definitely no pain, but was near comatose, not responding to sternal rubs, needed naloxone, Narcan, to reverse him out of it. So be very careful. Double check the doses and that sort of stuff. Now this is easier with E-Force being much more prominent. It's kind of done before that case there, but always double check. Other nice things about this, and this can be somewhat helpful for like mixed pain types, or maybe you have a neuropathic component, can actually block the reuptake of norepinephrine and serotonin. 5-HT is just another name for serotonin. This will become important when we talk about antidepressants a little bit later on in the psych section. But again, very long half-life, good from that standpoint. We are seeing it used for more chronic pain management cases like cancer and things like that. Other notable things with this is that it can cause QT prolongation. So, again, in and of itself, probably not a problem just by a single drug. But when you start to mix with other drugs, it can prolong QT. Imagine if someone who's on this, all of a sudden they got, say, a pneumonia and they got put on azithromycin. QT prolongation, right? So you got to be careful, or they get put on fluoroquinolone. Check an EKG, check their electrolytes, and make sure they're not going to be at risk for developing that, right? Because again, QT prolongation leads to torsades. What's the treatment for that? Magnesium, absolutely. Good. Okay. Next we have one called meperidine. This is actually I knew a pain management pharmacist who called this Demonol. They really dislike this drug, and so it's very limited use. But you will see if you work in the surgery setting here. The reason why we don't like it is because a lot of older patients who used to use this had poor kidney function. They can't clear it. When they couldn't clear it, it ended up developing this metabolite that caused seizures. So as old patients were taking it for chronic pain management, and they get seizures. And you're like, what the heck's going on here? Mainly due to that metabolite. So nowadays, the thing we're going to be using it for is going to be for rigors. You know what rigors are? So this happens sometimes in the post-operative setting. Patients will start to shiver a lot. If you want them to stop shivering, you will give them meperidine. I don't know the mechanism why that is. I just know that it works, right? So again, if you need to keep them still, what happens when you shiver? Well, yes, you shiver, but what physiologically what happens? You're using a lot of energy, you're producing heat, you're producing acids, so you don't necessarily want to do that. So by giving the patient meperidine, you can stop that. And in fact, if you're doing like a therapeutic hypothermia, say you have a person with a witness cardiac arrest and we do the therapeutic hypothermia, again, the body wants to maintain its normal temperature, so we'll give them meperidine to help prevent shivering when they're in that cold state. That, not necessarily. I'm not sure. I've not dealt with a whole lot of and again, I can only speak from my perspective, so I don't know if I've seen that a whole lot. There may be some cases in the OB-GYN realm where they want to use that. I'm not sure. I know my wife, when she was getting her epidural, she definitely had some shivering associated with that. But she never got any Demerol or anything like that. I don't know. I wish I knew it all, but I don't. Anyway, so again, be very careful with this. Only really use it in the surgical setting. You're not going to see it really elsewhere. Next up, we have buprenorphine. This is going to be a very good drug for trying to get patients off of their opioids if they're addicted to them. They have substance abuse problems. And so buprenorphine is very good. Oftentimes, it actually comes as a combination of Suboxone with naloxone. We said naloxone is actually the reversal agent. You're like, why in the heck would you combine those two together? Why do you think that would be the case? So, yes, but it depends on the route. So one of the things you'll find is naloxone does not absorb orally. Only can be absorbed if you give it as an injectable product. And so this is to try to subvert, if patients were to try to, say, crush up the pill and try to inject it. That way when they inject it, they have the naloxone there to hopefully try to prevent any toxicity from that. Does that really stop people? Not necessarily, but again, one of those things to consider. In fact, that's one of the big problems with a lot of prescription products is that they will crush them up and try to inject them, and that can be a problem with the controlled release preparations. So some of the things they've done to try to get around that is to make it to where if you try to crush the tablet, it turns into this kind of jelly kind of mass that you can't really pull the drug out of very easily. All kinds of ways they try to get around that, but patients, where there's a will, there's a way, as you'll find. But anyway. So buprenorphine is really good. The nice thing about this one is a good long half-life, but it's also a partial agonist, which means it's only going to partially activate the receptor. It's enough to prevent withdrawal, but not enough to necessarily get the same sort of euphoric effects they would get from a full agonist. And so this is one of the reasons why they've started to use it for opioid addiction, to try to wean people off of it. Okay. However, it binds very, very tightly to that receptor. And so one of the things you'll see when starting up buprenorphine is that you don't want to give it to them while they still have opioids in the system, because this binds really tight, but it's only a partial agonist. So imagine if I had a full dose of heroin in my system, feeling fine, and I give that buprenorphine, it's going to go and kick all that heroin off the receptors, and then the patient go into withdrawal. In fact, you've seen buprenorphine overdoses, and the patient presents, and they're going crazy. They're fighting people, and they're going buck wild, and you're like, what the heck? An overdose of an opioid should be comatose, right? It's not the case, but it was because they still had methadone in their system, took the buprenorphine, kicked it off, and then they put themselves into withdrawal. So that's something to consider there. So what you do when you have someone you want to start on this, you'll give them, you'll basically have them go off of their opioids, whatever they were using, wait till they start to have the symptoms of withdrawal. Again, it's usually in a monitored setting, like in a rehab facility or something. Once they start to have the withdrawal, then you give them the Suboxone. Then you at least know the drug's out of the system. You're not going to put them into withdrawal. You'll help to mitigate those symptoms. And then they're managed on that for a while, right? So something you're going to see there pretty commonly. Okay, so in general, this is the more common opioids you're going to run into for the most part. But in general, you want to use long-acting formulations for chronic pain. It's going to be able to help kind of deal with their basal pain throughout the day, and they'll be on something immediate release, short-acting, for breakthrough pain. Okay, so it could be on Oxycontin Q8 hours, long-acting oxycodone, and then be on Percocet, which is oxycodone and acetaminophen, every 4 to 6 hours as needed for breakthrough pain. Okay, that would be a valid set of prescriptions there that would be reasonable for that patient there. Okay, typically orals are going to be used most commonly. However, we can use things like transdermal routes for things like fentanyl. That's only going to be for chronic pain. We don't use transdermal products for acute pain. Why is that? Takes too long to kick in, right? So again, it's only going to be for the chronic patients there. And in some cases, we actually use intranasal routes as well. So for instance, if we have a kid comes into the ER and they're having a hard time getting an IV started on them because maybe they're moving around or they're scared or something like that, we can actually use the intranasal route. We'll give them a little intranasal fentanyl, and it actually does pretty well to help kind of get the process started and provide some pain relief for them. So again, route can be very important there. In general, though, start low and go slow, right? So if you think about it as like a magic show, does the magician come out and they saw the lady in half right away? No, you got to work up to that sort of thing, right? You can always give more, but you can't take it back. So don't start the show with a showstopper. Work your way up there, right? So again, I can give a little bit more drug if I need to, but I can't take it back once it's in the system. Start low, go slow. Anyway, other things you may see there. Anyone ever heard of a patient-controlled analgesia, or PCA? This is something you see very frequently in the inpatient side. PCA pump, absolutely. You'll see this a lot in the post-surgical setting. We use these all the time, or we use this for like our kids, like our sickle cell kids who are coming in for acute pain, who need to be managed on this. This is a very nice way to help limit how much opioid a patient needs by allowing them to control when they get it. Okay, and so that's why it's called patient-controlled analgesia. So is this good for someone who's intubated and sedated? No, because they can't mess with it, right? This is good for patients, who have the cognitive capacity to actually work with it. And what this does is it allows for a basal amount of drug to be administered, and then they can give themselves extra doses when they need it. Okay. Now, does that mean they can give themselves every single dose they want in the entire world? No. It's going to be on a lockout sort of basis, right? So you can say, I want it every 6 minutes or every 10 minutes with a total amount in a certain given period of time there.
Is that like when women's in labor
Mm-hmm.
and they get the epidural?
Mm-hmm.
Okay.
Yeah, essentially it's an epidural PCA there, right? Normally either see IV PCAs or we can do like an epidural PCA for sure. And it doesn't even have to be an opioid. Sometimes we'll have epidurals that will be done with just like a local anesthetic, like ropivacaine, if you ever see that. Usually the epidurals for labor, and it's actually fentanyl and ropivacaine are the most common one, the combination you're going to see given for that. But anyway, so the thing is that there's going to be an on-demand dose, and this is important because I want to talk about the what needs to go into the order to make it a valid prescription, to make it a valid order, right? So these are the components you need, because if you miss any of these, then you're going to be getting calls from the pharmacist, or the nurse is not going to know what to do with that order. So you have an on-demand dose, so what they're going to get when they hit the button. You're going to have a basal rate, which is the amount they're getting per hour. So if you want, say for instance like morphine, you're getting 1 milligram per hour, and they'll have like a on-demand dose of say 0.5 milligrams. Then you're going to give them a lockout interval, which is how often they can get the dose. 6 minutes, 10 minutes, 15 minutes, whatever it's going to be. And then typically you'll get like a total amount that they're allowed to get within a period of time. For whatever reason, usually we do 4 hours. So we'll say, okay, here's the max they can get in a total of 4 hours, including their basal rate plus their on-demand doses. Okay. So, and the nice thing here as well is because these things we can detect, we can monitor how often they're hitting the button. So say for instance, if they're getting it every 15 minutes, they're allowed to have an on-demand dose, but they're hitting it every 6. What do you think that tells you? They're still having pain, right? So then you can adjust what their basal rate is, give them more, and that way maybe they're not hitting the button so much. Okay, that's one thing you'll see. Now, if you come back and it's been 15 minutes and the patient's hit the button 347 times, we'll see that with kids sometimes. And kids will sit there and just play with the button, like they're kind of bored, they don't know what to do, so they'll sit there and hit the button. So either they're in a lot of pain, but usually they're sitting there chilling, or they're just playing with it. So again, taking into account kind of the clinical situation there. So a good example of a normal PCA order you may find is a morphine IV PCA, 1 milligram per hour, basal rate with 0.5 milligrams every 15 minutes on demand. And then the total, their 4-hour max would probably be, say they'd be getting 2 milligrams an hour, so 8 plus 4, so 12 milligrams in a full 4 hours. So again, you can do that math and double check me. But that's what a normal PCA order would look like. Again, here's a PCA pump here. Notice that this is usually like a plastic enclosure with a lock on it, so that way the nurse has to go in with the key, because otherwise the patient can go in and take the drug out, or they could try to program in their own settings. Like, I think I need a little bit more than that. Usually there's just sort of a code set with it. We changed it since then, but I remember when we first opened, they thought the head anesthesiologist was so cool. They put the code as 007. He's such a cool guy, but we changed it since then, so I can't do that. And here's what the patient's button would look like. Basically, it'd be on a cord, and you just kind of hit it whenever they need to. Okay, so as I mentioned, these are the requirements you need to have. So I already kind of went through that, and you can kind of see the total 4-hour max there. Okay, let's see. So other adverse effects. This is a big thing I want to focus on. I hope you guys don't mind if I go a few minutes over. But adverse effects, these are things you want to be knowing about. So frequent constipation. They're going to get constipated. You need to treat them with an appropriate bowel regimen. How do we do that? Talked about laxatives before. Mush and push. Mush means what? We're using an emollient, like a stool softener, right? So Docusate is good. Push means what? Stimulant. So you see Senna and Docusate are the common combination we're going to administer for those patients there. It's a mush and push sort of mentality, right? Because again, you need them because this is going to slow down the bowel. You need to give them something to try to make it easier to pass those stools there. Okay. Nausea, vomiting is pretty common here. Sedation is very common with this. Now, sedation, are you going to get tolerant to those effects? You will, yes. You'd absolutely get tolerant to the analgesic effects and the sedation effects over time, right? So again, this could be important to let them know. You probably don't want to go out to work. If you're operating heavy machinery, the first dose you take of this, but over time they can get tolerant to that thing, and can be functional. The histamine release is mostly going to be seen with codeine and morphine. So again, if they have that, they can switch over to something else like a hydromorphone, and then they should not have that issue there. Less frequently, things you're going to see, especially with high doses, like in overdoses, is going to be risk of respiratory depression. And then also there's going to be that risk for abuse and diversion seen with that. That's usually seen with addicted individuals. And again, is that only just the patients? Now, healthcare providers are very much at risk too, right? Anyone know the biggest healthcare group that's most likely to be diverting opioids in the hospital? Anesthesiology, actually. Yeah, because they have the most access to it, the most free access to the opioids. They are most likely to be abusing it. Who do you think is most likely to be selling the opioids? Pharmacists, actually. Yeah, pharmacists is actually more likely because again, we have access to huge amounts of it. We're not saying giving it to anyone, so we don't really have that capacity to be like, oh, I'm going to give the patient 2 milligrams of morphine. Here's one for you and one for me, right? But the pharmacy, like when I go in, I'm checking in the order, and I have easily thousands of dollars of morphine or fentanyl or whatever. I could easily just say, oh, we only received 100 of these, and we only got 200. But there's things in place. Not that I would ever do that because it just ain't worth it to me, right? But I'm sorry. I've not seen that show. There you go. See, so I prefer to keep my drug dealing legal, which is kind of funny because like in my neighborhood, I have 2 detectives for OPD and one guy who's a cop over at the VA, and so then we got 2 drug dealers right at the end of the street. So it's kind of funny. There's a bunch of cops and that's 2 drug dealers here. We're legal drug dealers, but still drug dealers. So anyway, to minimize the adverse effects, you want to start low, go slow, as we mentioned. See what the cause of the symptoms are, right? So again, you can maybe link it back to maybe some of the other medications they're on. Depends on the case there. Try switching to another opioid. So again, if fentanyl's not good for them, maybe switch them over to Dilaudid. If that's not good for them, maybe switch them over to morphine, right? So again, everyone's going to respond a little differently there. And I mentioned the mush and push. Now, when you think about a more opioid overdose, what are the 3 cardinal things you think about? How do you recognize a patient with opioid overdose? Respiratory depression, meiosis, CNS depression. Okay, those are the 3 cardinal signs there, right? Respiratory, CNS depression. Now, is every patient going to get miotic? That's a misnomer, right? So just because you see someone with pinpoint pupil, that does not mean that they have an opioid overdose. If I see someone who does not have pinpoint pupils, does not mean they are not an opioid overdose as well. But the respiratory and CNS depression are the biggest things you're going to watch out for, and that's the thing that's going to kill the patient, right? They're not protecting their airway, they stop breathing. That's basically what you're going to run into. So, as I mentioned, with the constipation, very common, but again, use fiber, fluid, mush and push is going to be the biggest thing to shoot for that. And I just want to talk about the antagonist real quick. Naloxone is the antagonist at the mu receptor. So if you have someone who has a suspected opioid overdose, and I give them naloxone, it should reverse it pretty quickly because this binds very tightly to the receptor. And whenever seen a naloxone reversal, what's it look like? Looks like an exorcism, right? assuming you give too big of a dose. There's a Nicolas Cage movie called Bringing Out the Dead. You can look it up. Just look up Narcan reversal or something like that. Did I show it to you one time? Okay. Yeah, so very good example of what that looks like, right? Somebody can look like death warmed over. You give them Narcan, they'll wake right up, and they'll usually be pretty mad at you. Usually vomiting, diarrhea. It's no good. The nice thing you can do is if you give them just the right amount of Narcan, is they start to yawn. Why do you think they yawn? Their respiratory drive is starting to wake up. So if you think about it, opioids, what they do is they depress your body's ability to sense that high CO2. So normally, if you think about it, when you hold your breath, what causes you to take another breath? Is it that your O2 levels are dropping too low? No, we got a lot of hemoglobin. We can carry out O2 for several minutes. It's the CO2 that builds up that causes us to breathe. So what happens is the opioids, they blunt that response to the CO2, so we don't have that urge to breathe at that point. That's why you get the respiratory depression. So when they yawn, that's them seeing that, oh, their brain is starting to detect, oh, I got too much CO2, let me yawn and breathe that off. So that's a nice sign to say, okay, well, great, my patient's starting to wake up a little bit. Do I need them to be awake necessarily? Most of the time, no. I'd rather them be asleep, but breathing, right? And so that's where things like end-tidal CO2 can be very useful to help to monitor and make sure they're not holding on to too much. So you're going to start to see more of that being used as time goes on. So anyway. But Narcan, no oral bioavailability, so it has to be given via injection. So either, and actually intranasal is starting to become a more prominent route as well for in the layperson sort of setting there. So the question is, who needs it? Probably everyone should have a prescription for it, just like an EpiPen, because everyone could be at risk for it. But again, if you're overdosed on opioids, can you administer that yourself? No, because you're going to be CNS depressed. You can't do that, right? So you need to have other people trained on how to respond to that. Now, if you're doing heroin, and you're at wherever you're doing heroin at, and your buddy sees you pass out, are they going to be likely to call 911 for you? That's a problem. If you have Narcan, they can give it to you and you wake up. The problem is Narcan only works for about 20 minutes or so. So if you still have drugs around, you're going to depress, and then you're still in the same boat you were before. So again, it's important to say, listen, like, it can be kind of a sticky wicket, right? Because again, if you're abusing these drugs, if you don't have a prescription for it, yes, that is illegal, but you still need to get that patient taken care of, right? So overall, it's probably better that more access to Narcan's out there. Some people feel it kind of promotes illegal use of these drugs, but probably overall, from a societal standpoint, it's probably a good thing, right? Very fast onset, but it can't induce withdrawal. So that's the thing you have to be really careful from with that standpoint. And then we have a few of them that work peripherally, peripheral acting opioid antagonists that are good for ileus after surgery, right? So sometimes we'll give these drugs that don't cross the blood-brain barrier, so you can still get opioids for your analgesia, but we're going to give you something to block the effects in the GI tract to wake that up and allow you to pass stools, pass gas, whatever you need to do, right? So that's very good from that standpoint. It can be used. So you ever see like alvimipan, methyl naltrexone, or Meloxicam? Those are the three common ones you're going to see for that. Okay, so that's all I'm going to talk about for today. Any questions I can answer? Let me check the board real quick.